Good morning and welcome. I'd like to call the Interim Finance Committee Subcommittee on Early Intervention Services, that meeting to order. We are in the process of taking in a number of documents that we want to share with the public and with members, and so those will be available on our website shortly in the full interest of making sure that everyone has all the materials that this subcommittee is considering. This morning, just to kind of give a quick overview of the agenda and talk through the items that you see, certainly we have two periods of public comment on the agenda as outlined, but generally those are for matters not necessarily contained in item number 3, presentation by the Department of Health and Human Services on the status of Early Intervention Services Program. My hope would be that I know since a number of members of the audience here would like to probably provide comment following the department's presentation, that public comment of that vein be reserved for that period. So with that, I would like to start the meeting with the roll call, please.
Senator Kiekerfer? Here. Senator Parks?
Present.
Mrs. Carlton?
Here.
Mr. Hambrick?
Here.
Chair Bobzien?
Here. Thank you. And of course, with that, moving to the first public comment period, if we have any such comment, we would entertain that now at any of our locations. We are connected, in addition to the Sawyer Building in Las Vegas, we are also connected out to Elko. So I don't know if we have anyone that would like to come forward at this point. If not, we would move to item 3, presentation by the Department of Health and Human Services on the status of Early Intervention Services Program. And welcome Ms. Liverati, anyone else? Okay. Welcome you to the table. Good morning.
Good morning, Chairman Bobzien and members of the committee. I am Mary Liverati, Administrator of the Division for Aging and Disability Services. With me is Tina Gerber-Wynn, who is our Deputy Administrator for the division. We also have Janet Murphy, who is our Deputy over Fiscal Affairs. Janet, wave at him. Yeah. She's just joined us at the division a few months ago, and we're very happy to have her with us. So you should have a presentation that looks kind of like this. Have a copy of that, everybody? Go ahead.
I believe so. I'm not seeing anyone raising their hand, so I think we're set to go.
Great. So if you turn to page 2, we would like to start giving kudos to our Child Find team. We just received a report in the last few weeks that indicate that we have exceeded our targets in the area of serving the birth to 1 year population. We have a target of 1%. We actually served 1.15%. That also exceeded the national average, which was 1.02%. The birth to 3 population, we have a target of 2%, serving 2% of the population. We exceeded that by 2.31% was our actual number. And that's based on the OSEP report. OSEP is the Office of Special Education Programs with the U.S. government. And that was based on 2011 data. If you turn to page 3, we thought we'd kind of give you a picture of where we are right now with our caseloads. So we're looking at caseloads of children that actually have an IFSP, and an IFSP is an Individualized Family Service Plan. For fiscal year 2012, the actual numbers we served 3,041 children. The state provided care to 1,707 children, and providers provided care to 1,334. What we have budgeted for fiscal year 2013 is that the state will provide care to 1,818 children. The private providers will provide, or I should say community providers tends to be the term everybody uses, 1,519 children. for a total of 3,334 children to be served this year. We do have 306 children that are waiting for services. That means that they've received their IFSP. They may receive some services, but they're not receiving all the services on their plan. And these children have exceeded the 30-day. We have a time limit or a benchmark of trying to get those services to children within 30 days. We have 306 children that have exceeded that 30-day period, and they're waiting for 420 different services. You know, as you know, the services that we seem to have a hard time recruiting and providing are speech and language pathology, intensive behavioral therapy, developmental therapies and in specialized instruction, occupational therapy and physical therapy are the main areas. Although I will say speech and language pathology overwhelmingly is the service that we have a difficulty in recruiting providers for. On the next page, page 4, we've got a breakdown for the community providers. These are the numbers for September 2012 that was budgeted. They would be serving 1,311. The actual number they were serving at the end of September of this year was 1,340, so slightly above that number. I won't go through this, but unless you want me to, but you can see who the providers are, and the number of children that they are serving is listed right next to them. And please stop me if you have questions along the way. If you go to page 5, there's been a lot of concern over having a budget shortfall. We had a shortfall last year and had to adjust some monies. We will be coming to we're aging, but actually the money's over in the Health Division. The Health Division will be bringing a work program to the December IFC to move some money. If you look at what we've budgeted here, state contractors, we had budgeted $3 million. The projected amount for state contractors is $4.1 million, and we are short about $1.1 million. The community providers were budgeted at $9.4 million, and they're projected to come in at about $9.4 million. The shortfall, the $1.1 million, we will move money to cover that shortfall, and that money will be covered by increased Medicaid billing, some money there, $200,000, increased Part C funds, which do come through the Aging and Disability Services Division. We receive the Part C money, which is our federal money, and then salary savings of about $200,000. So this may change slightly, but because the work program is being put together right now, but we thought you'd be interested to know that will come to your next meeting in December. Tina Gerber-Wynn is going to go through the services themselves and kind of what our vision is going forward.
Good morning. For the record, my name is Tina Gerber-Wynn, and I'm the Deputy Administrator of our Programs for Aging and Disability Services. And on page 6, we had discussions about how to diagram for you what the current terrain is of the program, just to make clear who has a role in the service delivery and to clarify where we're trying to go to on the next page. So currently, the Health Division has been in charge of the items that are listed on this page. They established provider agreements, which outline the roles and responsibilities of the 7 providers or 8 providers that we listed earlier. They started working on this in 2007 when the private providers, community providers came into play. They also have worked diligently in 3 to 4 rate studies that were trying to firm up the rate for the community providers, which has varied over the last 4 years, to firm that up so that we have proper access to care. They also manage the payments to the community providers. The other thing that the Health Division is in charge of is child find, which Mary reflected in the first slide, where we try to find children in the community who might be experiencing a developmental delay and make them aware, their families aware of the program. They manage the intake and the initial screening of children and then help them with service coordination so they can access care. Develop the IFSP, which is the authorization for care, and provide direct services in those cases that are not handled by the community providers. As far as the community providers, again, we've noted that they provide service coordination, IFSP development, and direct services. And some of that does mimic what the state staff do for the cases that they retain at the state level. And then our agency as a whole, we apply for the federal grant, which has been averaging about $3.9 million for the last 4 years. We did have some ARA funding earlier, but that's no longer in play in our budget. We also complete all the monitoring reports and quality activities for the program, as well as manage the data through our Tracking All Children and Services, which is TRAC, and that's our data system that we manage. Personnel development, as part of the Part C requirements, we are to assure that the providers, anyone providing services, are competent and aware of their role and scope, so we provide the technical assistance as well as the curriculum for some of the disciplines that are otherwise not certified, like a PT or an OT. They have certification requirements. For other services, we devise a curriculum and try and make that accessible to providers, including health division staff. Also, the procedural safeguards, which are the complaint resolution complaint resolution structure for families. So we give notice when plans change, when children aren't eligible for the program, when they leave the program, so that parents can then exercise their rights in case they don't agree with the decisions we make in the program. So our office maintains that structure and advises the community providers and the health division on how to fulfill the federal requirements regarding that. And then the last thing is a complaint investigation, and I think people are aware that there were some concerns and a systemic complaint issued by NDALC, Nevada Disability Advocacy Law Center, about us giving proper notice and access to care within the system. So our staff manage that complaint system and resolve issues with families. So that's what it's like today. I didn't know if there was any questions. It's a lot of detail.
We'll probably have a whole bunch of questions, but
Okay.
please proceed for now.
All right. Then on the next page, page 7, is where we have talked collaboratively with community providers, with health division staff, with our department, Mary and Janet and I. We talk about this a lot as far as where we want to go with this program. And in the beginning, the top of this is that it will all be under Aging and Disability Services Division. And we outline the same duties except for under different compartments within our agency. We would still manage the quality assurance with staff who would apply for the federal grant. I mean, this is repetitive: monitoring and reporting, manage the data system, personnel development, all those procedural safeguards. We would have staff earmarked to do those things. Right now we have 8 people, and our thought would be, as we evolve into this newly devised system or improved system, that other staff would participate in these functions, including health division staff who would be more involved in the day-to-day monitoring of the community level providers. We would also have fiscal staff that would concentrate on the provider agreements or contracts, depending on how we go forward. Because we have a set amount of money, obviously we want to have a right fit with the providers, assuring they know their requirements, spending a lot of time training them and giving technical assistance so they succeed in the delivery of services. And also the development of rates to work on that and finalize that and keep that up to date so that we have proper access, as I mentioned. And then the payment system that the health division already does, so the community providers would continue to be paid through Aging and Disability Services in the future. And then for program management, again, the health division staff and our current staff would work on the child find, the intake, service coordination, and the development of the care plan, IFSP, and the community providers would provide the direct service. And that basically is covering all the tasks I had on the previous page, just compartmentalizing them in a different structure, still addressing them all the same way, with the community providers rendering the direct services and working towards them providing a majority of the care in the community. One of the things we haven't really noted in some of this is that this is just the direct service piece. We also provide some services for maternal and child health grants and community grants that the health division has. I know there's craniofacial service that we provide, hearing screenings for newborns, some of the metabolic diagnoses and remedies. So those are health division programs that got wrapped into early intervention. They're not generally part of the service delivery, but it does allow us to find kids who might need these specialized services and get them into care sooner. So it is a separate funding. It's a separate program in some states, but we've put it into our early intervention system just because it's easier for parents who are trying to find care. We're assessing children so that we don't make them go through a separate process to access some of these other benefits. So I think sometimes that gets confusing to people that they're part of the general service delivery under early intervention. Not always, but we are going to continue to have them as part of the service design in this program, at least as an access point to families. So I don't know if there's anything else.
Okay, so just if I could have you restate.
The changes, this time from the prism of responsibilities across the divisions.
Right.
What's changing there? I mean,
Okay.
it's here, but I'd like to hear it in your words.
Okay.
And then also the changes for the community providers.
Okay. For the department as a whole.
And perhaps even what the theorized benefits are going to be for making the changes.
Okay. If you want. No, okay. We're negotiating a handoff.
Toss here. Who takes the question?
Well, currently.
That says so much.
Oh, I hope that's a good thing. We collaborate. I think the thing, we're both confident in the system design, if that's the point. The health division and early intervention, or in Part C office, were initially together when this whole thing started in 2007. And there was some
Maybe I should give you a little more history.
Okay.
Actually, I think it was back in 2003 session that we combined a number of programs. I don't know if anyone remembers the Happy program and First Steps, I think. And our historian is sitting in the back there, and he could probably correct my. Mike Weldon knows all the.
He better
can
be
remember,
more than the historian.
he remembers everything much better than I do. But, you know, we discovered back with Governor Kenny Gwynn, he had a real passion to serve children and provide better services for these little ones. And so he did some restructuring in the 2003 session to bring all these programs together, again, to make it easier on families, to try to stretch our dollars, because the federal money has never been more than about $4 million. And then we put in, I don't know, those days Michael probably shout out I think it was like $10, $12 million we started, I don't know, someplace there. We're now way over $20 million. I think we're up to 25 or 26 million of state general fund. But the purpose was, how do we get the best bang for the buck and a better service to families? So we did some consolidation back then. What we're looking at now is really looking at aging and disability services becoming the primary deliverer of services for people with disabilities. And so the department has been meeting for, well, actually we've been meeting for, I think, when Ben still worked for us years ago, or I mean Senator Kiefer. Sorry, Your Honor. But, you know, we've been trying to look at how do we improve services, streamline services, be more cost effective, and serve families better, which is always the number one concern. And so we have been looking at what disability services could come over, and when we formed Aging and Disability Services. And we did bring over the Office of Disability Services, but we always had a laundry list of other services that we thought would make a nice fit. Because many of these families are having to go to different agencies to get services, and wouldn't it be great if we had one agency that would do disability services across the lifespan, so that you didn't have to keep jumping out of one system and into another. So that was kind of where we've been going for the last few years, and this is kind of what I think of as the next step, bringing developmental services from mental health and developmental services over to aging and disability services, and then the early intervention services also over. So just back to our history lesson, the Part C office was under the Health Division several years ago. Some advocates were concerned that the Part C office is supposed to be the ones that are watching, ensuring compliance and safeguarding the rights of parents, and that if they were housed together with the same unit, which they actually were in the same office and shared space and all that, that they couldn't be objective. So we did move it to the Director's Office of the Department of Health and Human Services for a couple of years, and then it went over to the Office of Disability Services, which then went over to the Office of Disability and Aging and Disability Services. So we did have the Part C office separated from the early intervention services. We now feel, though, that we can have those safeguards in place and actually utilize the Part C office to become more of a technical assistance, helping our providers to provide better care, looking at cutting-edge practices and best practices in other states to help, instead of always doing things on the back end, how about we build quality in right from the beginning? And that's kind of our vision going with bringing all these under one agency. So, Tina, I'll let you take it from there if you want. Oh, if you don't want, I can keep going, but...
So, this is Tina Gerber-Wynn, for the record. So your question was, describe it in my own words besides the chart about how it will come together. And the roles. And the roles. Well, right now, as Mary mentioned...
And the why.
And the why. Okay. The why is that the rules that we've talked about with the Part C grant, people see that as an overlay when it really has to be embedded in the program. And the ownership of that would be better served if all the staff understood it from the beginning, preliminarily, what it means. How to assure that people have their rights, to talk about the benchmarks of the program from the beginning, and to train people to look for some of the quality issues that might come up along the way, which is what Mary said, right away. And I think that it's important for them to work as a team. And part of this separation in agency, whether it was meant to be that way or not, has created some difficulties for them to see themselves as a team. But they have to be if the quality is going to improve within the program. It's just like a lot of the other services that we provide. I thought about it several times. We have a waiver program that we run for Medicaid. There's several waivers we run. The same principle applies. We ask the feds for approval to serve people. We assure quality in 5 or 6 steps. Part C has 14. The waivers have 5. Where you assure you have quality providers, you train them. You let people into the program that have the right service need or level of care. And you make sure that they have a way to advocate and complain or address issues or have the services they need and direct their care within the program. And you pay them appropriate rates, and you make sure that people are checked on in that system, managing it. And this is what we're trying to do for early intervention program by bringing the staff back together and assuring they understand the benchmarks of the program and they're trained to follow through on that on a constant process. And the development of the provider agreements is part of that. I think the system has grown so fast that it's gotten out of our reach in some areas that we need to just pull it back in. And what I mean by that is if you add 200 or 300 kids a year to a program, that's a lot of growth. And in looking back in the last 5 or 6 years, that seems to be how many people we're adding. The state needs capacity to train people to take on the care of these kids because we don't have a lot of time to address the needs they have. 0 to 3, that goes in the blink of an eye in development. And so the hope would be that the state staff can concentrate on recruiting the providers, training the providers, getting the kids into the system and onto a care plan with the competent provider, whether it's a state staff or community provider, and addressing those needs within the timeframes that are set on the plan. So again, the cohesion is the staff working together, understanding each role, defining that more clearly, and assuring we meet the federal requirements like it's part of a daily operation, not something that we talk about only when there's a problem. It's just part of assuring that we understand the outcome of the system.
Also, this is Mary Liberati again for the record. Also, since you're the money committee, you might be interested to know that we've had this system where one agency is getting the federal grant, but all the state dollars are over sitting in the... So Aging and Disability Services has the federal grant money, but the Health Division has the direct service, well, all the money for the program that's general fund. So we've had a disconnect, and we've had to do a lot of trying to coordinate between those funding sources, and we shift monies back, and when Health Division has a shortfall, as we talked about a little bit ago, being able to maximize the money that we have coming through the Part C office. And I think that I personally have seen a conflict where the Health Division is the one that has been managing those contracts. It really makes more sense that the Part C office handles contracts with providers so that we look at the health staff, if it stayed at the Health Division, as a provider, and the community providers Because the way the system's working now is the money flows through the health division, and then they are giving out the referrals to the community providers. So it can be, a difficult system as to start, stop, giving referrals out or not holding. I mean, you've got testimony from previous meetings that you've had about how hard it is to actually manage the flow of the service dollars with, if they don't know soon enough, they can't spend the dollars, then we have money that isn't spent, and yet we have children that need services. So, trying to streamline the system on the money side also, where it comes through one place, we have a single authority for the program, and we can maximize that money and be more efficient in getting those services out to our families.
This is Tina Gerberwin. I'm not sure if we needed to add more or not. Based on the look on your face, I'll let you ask.
I'm trying to thread together the various comments that I heard, and I appreciate you, speaking more or less off the cuff and just providing your perspectives. With the explosion in caseload growth and the sense that you had to bring things back in, I think was the term, and that's what led to the idea that the IFSP development would come in exclusively then under your shop, and that would be removed as a responsibility or as one of the activities that is done by the community providers. Is that part of, are those two notions connected?
For the record, this is Tina Gerberwin. And we would get to page 8 and we would answer some of those questions, but I think that's a good thing. You're anticipating where we're trying to go. The role development is definitely something that needs to be locked, because what you're talking about is who retains the IFSP versus of state versus the provider community. And we've had the opportunity to have 4 meetings that Mary Wary called together the community providers and the state staff to address that. And that's one of the things we have to finalize, because there's several models other states use. So we haven't made a final decision on that. There's nuances to work out in that to make sure it's efficient and that the continuity of care exists, because I think some people are worried if we develop the plan, the community providers will not be able to pick it up and be as efficient. So those are definitely things that we need to finalize as we go forward, and that's what we've been working on.
So you're trying to thread the needle between Part C compliance, right? That's part of this. The continuity of care, and with that, frankly, what the experience is of the families having to go back and forth between the two. And then ultimately, is that scalable, and are you going to be able to still realize efficiencies from doing it that way? Is that more or less what you're trying to blend?
That's correct.
Okay.
And in that, this is Tina Gerberwin, is the staff task so that they're clear on what their role is, because this is a change, so people will have to do different things. Then there'll be equally important things as to what they do today, and they'll be within the scope of what their classification is. It might just be a different role, which allows for that continuity of care, a timely assessment into the program, the establishment of a plan of care, the referral to the right provider, whether it be the state staff with the level of expertise that might be necessary versus the community provider. Those are the things that we need to work on and finalize and have properly acknowledged by the community, by families, by stakeholders, by the providers, so that they understand the role they're taking on in this system.
Right. So right provider, that's a tricky one, right? I mean, you're talking about capacity, you're talking about fit with what the family requests and desires are, you're talking about.
That's exactly correct.
Okay.
And that's definitely what we do now in other programs. I would contend that we can always improve on that system. Any program can improve, and that's what we're trying to do with this particular one, make those processes clearer so that people know what they're taking on, whether it is a state personnel, community provider, a family, so they understand what their rights are and what they should be asking the system to provide. So again, we wanted to make sure that the rate was clearly delineated, firming up the rate studies that the Health Division has started to make sure that the rate's appropriate so that the access to care is there and that we have community providers who are willing to enter into the care system, and assure that our staff know how they're going to be part of that. And they are vital in this to find the children, to assess the children, and to train the providers to properly serve the children. And then we would pay the bills, which is what we do right now, to the community providers, or we pay our staff to provide the work.
Okay, and so specific to that discussion of rates and everything else, when's that going to happen? I mean, you're in the middle of building your executive budget. We're months away from start of session. I can only assume we're going to have to be looking at this on a very grand scale next time. Is that still going to be a question mark when we get to session, or is we going to have resolution?
This is Mary Liverati for the record. We've already submitted our budgets, and so we have planned for the next 2 years. We have adjusted the rate based on some of the information that comes in, but it's I guess I really can't tell you too much at this point because our budgets are confidential until next week. If you'd held your meeting next week, I probably could share a little bit more information with you. But I will say that some of the questions that you had that we've testified already on, which in August, I believe, at your meeting, IFC meeting, there was an impression maybe that we would go 100% to community providers by the end of this year. We will not be doing that. We will not even achieve that over the next biennium. We are in a state right now of looking at locking in what that provider rate is and making sure access to service is another big piece. So we've got to make sure those rates are attractive enough that providers want to come in and meet all those federal requirements and provide a high quality service. So, you know, we're still negotiating there, but I will tell you that we will have this locked in before the session starts. Because we have to. We can't move ahead if we don't make some of these decisions and get these things refined down. So we've been working on it for the past few months, and we're going to continue to work on it. My hope would be is that we have it by December, because we've got to fall on something and get a plan to go forward to make the transition happen.
Right. So you'll be locked into a rate, but we really won't know how it'll work. I mean, it's, you know.
Well, I mean, this is Mary Liverati again for the record.
I mean, you're going to try to capture where all the the discussions and the negotiations are, and try to come up with the best plan, right? But we're still going to have some unknowns, and that's going to be
I think
what we're facing the next biennium.
I would agree with you. I mean, anytime we try anything new, I think, or changing systems, I think a vital point of doing that, we have to try to make changes, but we have to always take a step back and look at. It's like flying a plane. You think you're going here, but you might veer off course. We need to re-examine where we are going as we are implementing to make some changes along the way, too. I've never put a program up in my 33 years of state service that we ended up where we thought we were when we started. So, we've got to be flexible enough to be able to make those changes.
Sure. Okay.
So, but definitely we want to have a transition plan in place so that when you, as legislators, meet in 2013, we can present that to you.
Okay. Well, and we can return to that discussion toward the end of this, but for now, unless there's other questions, since I've interrupted the presentation, this is probably a pretty good break to have the interim questions. We do have a question from Senator Kiekefer, and then I'll be happy to send it down to Assemblywoman Carlton. Is it you, or do you have other members down there?
Mr. Hambrick also has a question,
okay,
Mr. Chairman.
Fantastic. We'll start up here in Carson with Senator Kiekefer.
Thank you, Mr. Chairman. I've got a couple specific questions about your presentation, and the first is on page 3, where you talk about the number of children and the number of services being currently on the wait list. Are those services, are the children who are waiting for those services being served currently by the state or by the community providers, or a hybrid of the two?
This is Mary Liverati. Actually, it's both.
Okay.
So they're waiting for some state providers and some community providers, and we do have some information if you're interested in that.
Okay. And is the type of service that we're not finding consistent between the state and the community providers? Is it continually speech therapy and language pathology primarily?
This is Mary Liverati for the record. Yes, speech pathology is the service that we, especially at the state level, are having a hard time attracting and being able to contract with. And I guess I should back up. In my presentation, we tried to do kind of a high overview, but when we talk about the services that the state and the providers provide are on page 3. The state, we have two entities that are providing services. So we have state employees, and then we also have contracted services that are actually what we refer to sometimes as Category 12. Category 14 is our community providers, but Category 12 is where we actually contract out with service providers that are not state employees. So a lot of this service is being provided not by state employees, but we call it on the state side because we're managing it over with the state workers. So there is a distinguish there that I think you might be interested in knowing about, or you probably remember that. But I just wanted to point that out. So we're contracting with community providers. We're also contracting with people directly with the state, but who are not state workers, and that's where we see the greatest need in being able to attract those therapies. If you look at the community providers versus our state providers, contract providers, the community providers, because they, I don't know, they're able to do things that we're slow in government to do, and they could probably, when they come up, they could probably explain why. But I think that you have the numbers of the.
Yeah, it's a wait list from September.
Okay, so if we look real quick at, where's the community provider one though?
That's them.
Oh, okay. So if we look at the children of the 438 that are waiting for services right now, the majority are over on the state side through our early intervention services. I'm going to do the math very quickly, but out of the 438, we have about 420 are on the state side. If we look at the community providers, we have, 11 children that are waiting for services. So that just kind of, I think, will help you answer your question.
Thank you. My next question was on, and I know that we'll probably get into it in the budget, request or the work program that's going to come over, the $200,000 in salary savings, is that natural or was that held open, positions that were held open?
This is Mary Lavrati for the record. We are holding positions. We have, the health division is holding positions. In the effort to make sure that when we change roles that it's never our intention to lay anybody off, and we are planning not to lay anybody off, but when we change the roles of some of the folks that we have on staff, we're not filling certain positions. But that being said, under Category 12, which is our contracted services, we can contract with temporary employees. We just won't bring them on as state employees. Sure. So we're filling the need through Category 12 for those kind of needs, is my understanding. I'm speaking for the health division, and Mary Wary is here, who's the deputy for the health division, who could probably explain that more if you have more questions on it.
Okay, we'll have to hear that reiterated by the division. Thank you.
One more, Mr. Chairman. And Tina, when you talked about the non-EIS programs that are administered through the EIS program, are those individuals who are providing those services then sort of cost allocated through the program, or do they have a separate and wholly segregated funding stream for those programs?
I'm going to have to defer to Mary Wary.
Okay.
You know what, why don't we do this, because this could go back and forth a lot, and we could burn a lot of time doing this. So why don't we just hold on those questions that are more for the division, just knowing that we're going to have this back and forth. So rather than having Mary jump up and down for the next hour, we'll stick with one division and then we'll go to the other one. So is that right? Exactly. So Senator, does that work for you? Okay, great. Thank you so much. Okay, we're going to go down south to Assemblywoman Carlton.
Thank you, Mr. Chairman. I'll let Mr. Hambrick go first, and then I'll follow up. Thank you.
Thank you, Maggie. I guess mine is more a broad question, but in the testimony in the past few minutes, my untrained ear might have picked up at least two broadsides to the community providers. And I'm somewhat concerned. I would like to have that expounded upon a little bit, or even offline and privately, exactly what the specific concerns are with the community providers, because I like the public-private partnership aspect, and if a provider is not up to par, I'd like to find out what provider you may be referring to, or is it a category? I mean, I've talked to several of these providers and I'm very impressed with their, I guess, from my perspective, level of competence. But I'd just like to have this explained more as you, according to testimony, you pull things back because you're concerned with the community providers. And some of it was answered, the fact, with your Category 12. And I like bureaucratic language. I worked with it for 30 years, but Category 12 to me are still private providers, even though they're in the contract. But this pulling back and somewhat castigating the community providers, I'd like some more explanation, either in testimony, but Mr. Chairman, if we don't have time, that surely can be answered offline and shared with the panel at a later date.
Well, we have this subcommittee so that we don't have to do it offline. So let's go ahead and jump in.
For the record, this is Tina Gerber-Wynn. I would like to say to the community providers, if they had the impression that we're castigating them, that is not true. There have been strong partners in this relationship. What we mean by reeling back or pulling back is just so that we can manage the financial part of this correctly and assure that we can afford the services and that we're spending, as we've noted to you in our budgets, and we want to make sure that that stays true to form. We do have issues where Mary's talking about, not issues, I shouldn't say it that way. We want to manage so that community...
Issues is a fairly neutral term. I'm surprised that you...
Well, I'm sensitive to terminology. I don't want to... There's improvements that we need to make. We want to make sure we can forecast where our budget expenditures are going to be, whether it's in Category 1, going to our bureaucracy, 12, or 14, so that we can give notice on where we're spending our money. And the hope is that we can move from those categories to afford access to the care. But we have to plan ahead and tell you when we're making those changes. So that's basically what I'm talking about as far as managing. As far as the community providers, it's just to set clear expectations. It's not to state that the current providers are not capable. People are happy with the services they provide. Children generally are getting into care within the time frames according to the rules, and we don't have concerns about that. There's a lot of providers who want to come into this system of care, and they need to be prepared to understand their obligations. And as we've grown so quickly with community providers, we need to, as an agency, give them clear guidance in writing and in the contract or the provider agreement, and make sure that everyone understands what they're to be doing. So that's the point of it. Not because they're not doing well, it's because we have to make sure that new people entering understand the obligations of the system.
This is Mary Lavrati for the record, and I'd also like to say the reason for stepping back also is that we haven't been bringing our own staff along fast enough, and part of that is so that we can do more work with our own staff if we haven't clarified what their role is going to be and have that discussion with them. We've got more times needed for implementation. Rather than rush through it, we'd like to do it in an orderly, phased fashion so that we want no disruptions to service and no impact on families. So, it's got to be our main concern, and that was the reason for stepping back, to make sure that we do handle it in a very orderly, phased-in process. And we at the Aging and Disability Division, haven't been as involved as the Health Division, but we're trying to come up to speed ourselves if we're going to take this over. And I think we just felt that we wanted to make it a little bit slower process. The Health Division, and Mary Wary can talk about that when she comes up, was looking at the money and making sure that we can get as much money out to services. But as I already said, we decided to slow the process down. That was a decision made from our side mainly with the Health Division. So, but it's not to mean that anybody's done anything wrong.
Thank you, Mr. Chairman.
Okay, so Carlton, do you have any questions at this point?
Yes, thank you, Mr. Chairman. I just want to make sure that, I'm on the right page and looking at all the right information, because in the IFC meetings that we had, there was talk of a pilot project, and from everything that I understand, the conversation we're having right now is basically the implementation of this project, even though I haven't heard that term used. So I just want to make sure that's what we're really talking about here today. Am I correct?
This is Mary Lavrati for the record. Yes, we've kind of gone away from that pilot project terminology to say that, a decision has been made that we're going to try to move towards community providers.
Okay.
And a blend.
And Mr. Chairman, if I may, that's fine. I know how much time we have here. So we're no longer talking about a pilot project. We're talking about a systemic change in how we deliver services to these children.
This is Mary LeBron.
Is that correct?
That is correct.
Okay. And Mr. Chairman, you may know more about this since you've worked in this area a little more than I have, but I'm just curious where the public policy discussion on this has been, or if this is the actual venue that we're having the discussion. It seems to me with such a big change that some policy committees might have been consulted on this when we're talking about, will this really serve these children? And ultimately, that's what this is all about, is will the children get better service from this? And those are my concerns. We've seemed to gotten in the weeds with, all the contractors and everything else, but we haven't had the actual, large policy discussion of, will this be the best thing for the children of this state? So did I miss something, Mr. Chairman?
No, I think that's exactly the questions that we need to have answered, and I would at some point like to hear from council, I think, on this very topic, is how the legislature interfaces with this whole process. And I think this has been the source of discomfort throughout all of this. I mean, when we remember back to last session, we had the issue to start with the calculation of the wait list, and we came in and tried to address that with some additional funding, and then we come back and we find out that the clinic environment focus was not going to be something that was going to be compliant. Then we had to change again. Then we're hearing about a pilot program. Now we're hearing about the moves to transition and getting ready for the next budget presentation. All the while, freezing positions. I mean, I appreciate the assurance that you're still able to serve with contracted positions, although I think we need to spend a little more time on that because I don't think many of us are comfortable with that at this point. But, yeah, at what point do we actually have a discussion during the session about whether or not this is really the way to go? And so I guess at some point it would be good to hear from council just kind of on what the role is, what the what the course forward is for the next legislative session. Is that am I in line with your thinking?
And I appreciate that, Mr. Chairman. I truly appreciate that because I've been sitting here taking notes and going through all the documents that we're getting from all the folks who are involved in this, and the underlying theme of all of them is, will this serve the children better, and which is ultimately our goal. And secondly, will we then be in compliance with federal law, because that would kind of be nice to do too if we could pull that one off in conjunction with serving the children, since we haven't been in compliance for a while. I have a number of questions on employees, contractors, for-profit, non-profit, community providers, all those types of things. But now that we've gotten this part on the record, I'll be happy to wait on all those questions until we finish the presentation and we get into the nitty-gritty of the discussion of the providers, if that would be okay.
Well, I think they just waived off any closing statements and are ready and willing to face the full brunt of questioning at this point, since we're already there. So please continue.
And thank you, Mr. Chairman. I do appreciate that. I think what I'd like to get into is I think the wait list bothers us the most because that impacts the children the most. It's my understanding that as the system works now, children are referred to the either state contractors or community providers, for-profit or non-profits. And if they don't have slots available, they can turn them back to the state, and then the state will try to find someone else. So ultimately, the burden of the wait list falls upon the state, not upon the community providers. Do I understand that correctly?
And real quick before we answer that, and that is a very important question to ask, and my apologies, Assemblywoman, as I'm trying to do air traffic control here, realizing that the first division had concluded their remarks, but we had not yet received the comments of the second division in play. So if we could do this, why don't we hold, if for now, the first round of questions to be delivered to Aging and Disability Services, if we can conclude those and agree that we can then hear from the Health Division on their take on all of this, receive their presentation, and then go into questions for the Health Division. Does that make sense for everyone?
Thank you, Mr. Chairman. I appreciate that. I just hope that with all this confusion, I can figure out who to really ask the question of, but I'll do my best. Thank you.
I'm hoping to be able to arrive at that same place. So yes, let's. So with that, let's hear from the division, their perspectives.
Thank you. For the record, Mary Wary, Deputy Clinical Services, Nevada State Health Division. So if you don't mind, if we could step to page 17 of the LCB fiscal staff's handout, the booklet.
Okay, stand by. Hang on. Let's make sure everyone's got that.
Sure thing.
Paper shuffle, paper shuffle.
Mm-hmm. Thank you. There you go. All the funnest place. Sorry, Karen. Oh, it's okay. Are we ready? Okay.
Okay, so that's the one with the base budget and M200 caseload growth net shortfall?
Correct.
Chart.
Thank you.
Okay, thank you.
Mary Way for the record. So if you look at the inset box down at the bottom that speaks to the legislative letter of intent that the legislature requested from this last session, 2011 session, basically what we've been trying to do is satisfy that letter of intent. This has been a difficult to manage budget. It's been a difficult to predict budget. The legislature has done an outstanding job from my perception. I've been with the division for 4.5 years, and consistently the legislature has funded providing services to children even though other programs have been cut. And so on behalf of the children and family, we're very grateful for that. The challenge that we've been experiencing, and I think it's what was reflected in the LCB fiscal staff's efforts to try and drill down and understand the budget development from last session, is that when you have this combo platter of community partners and state staff, the financing of those two are so different. One you can predict, the other you can't predict. And so when we had the request for us to develop a reasonable methodology that would consistently be used to calculate the budget for caseload, that's what we've been trying to set out to do. We've already established that the state staff play a very important role in service delivery. We use contractors as a part of that model, but we don't have a set dollar amount. Whatever the IFSP services are, for each individual IFSP that contractors are used to provide those services, we have no control over that process. With the private sector, where we have this capitated rate, which is similar to a managed care kind of a situation, we know that for $565 per month per IFSP, children are going to get all the services that they need on the IFSP. Part C is the regulatory oversight to assure that children are getting what they need in their service delivery package on the IFSP. So I'm not aware of any finding that has suggested that the private sector has underserved children. We had the first rate study done right after the last legislative session, and it revealed that the state costs more money to provide services than the private sector does. Executive branch audit was just completed this year, and it showed the same thing, that not only does the state provide more services, they provide more expensive services. So back to the letter of intent, what I've been moving towards with the private sector and with the state staff was to try and define the roles. What is the role of the state to be the safety net for the system, to assure that children are getting the services that they need, to assure that the procedural safeguards are being maintained? And then what is the role of the private sector to assure that we're spending every dollar we have as cost effectively as possible, but that we have some kind of a fixed rate for those things? So the Phase 4 rate study really takes us to that conclusion. I've been trying to move towards having a set staffing ratio so that if the caseload projections are $4,000, for example, that we know exactly how many developmental service specialists we need to serve that number of children, that we know how many administrative assistants we need to provide support to the system, that we know how many accounting assistants we need to collect the billing. And then, on the other hand, in Category 14, we would know exactly how much money we need to pay the private sector for the urban settings, the rural settings, and the frontier settings. One of your questions earlier to the non-Part C services, if you go to page 147 in that same packet, I think this may answer one of the legislators' questions. Page 147 and 149 list the state staff and the contractors or the contract dollars used to fund the non-Part C services that Tina Gerber-Wynn was speaking to earlier. And page 151 shows the total dollar amount used to fund what we call the special children's clinics, the metabolic screening program. And we serve children up to the age of 19 in that program. The newborn hearing program, that's a follow-up to the legislative mandate that all children are screened for hearing. Some children fall out, and so they come into our program for follow-up. So that non-Part C section was part of what I was trying to tease out so that when we go back to the letter of intent, the legislature and the executive branch have very clear definition to what it's going to cost in this program to continue to subsidize the services that we're providing, both Part C services and non-Part C services. Does that help?
Yes.
So everything that has flown out of this discussion, we had 2 summits this last winter, spring, with the private sector, with PEP, with representatives from the autism community, with state staff, with Part C staff, people from ADSD, people from the Developmental Services Division, in an effort to bring people to the table to develop consensus so that we were solving these problems and not having to bring them to the legislature to say, well, you solve the problem. So we've been trying to collaborate for the last 6 months and have reached consensus on a number of these issues, and that's why in June we had our first meeting to really start moving forward to roll out what I was referring to as the pilot to test the concepts that we all had consensus on. Is it going to work, or does it need tweaked, so that when we came into the legislative session to testify next spring, that we could tell you clearly, honestly, with experience, how the system was working and what our confidence level was in terms of how the budget would be implemented for the next session.
Okay, and I want to stop you right there because I think that's the key point, is the pilot and the communications about the pilot, the purpose of the pilot, what has been examined in the pilot has been murky at best. I have heard discussion of the pilot, as you just said, being able to demonstrate the value of the model and the concepts involved and to derive some lessons learned, et cetera. But then we've also heard before IFC the pilot referred to as testing and identifying the barriers to implementation, as if the concept and the model was a foregone conclusion. And I think that that's been where the hang-up has been for many members of the Interim Finance Committee, is what exactly are we testing here? And so if we have, to your immediately previous statement, gone through a pilot to examine the models, when can we get information about what was, what the design was, what was studied, what was examined, what the results were, everything else, ahead of the next session? I mean, are we waiting to receive that before next session, or given the fact that this has been such a controversial issue throughout the entire interim, can there be delivery of those findings now so that we are prepared for the fuller conversation before the full legislature?
If I may, Mary Warrior, for the record, I can't speak on behalf of the Aging Disability Services Division, but I think that's what Mary Liverati was referring to when she said that this summer, when ADSD was starting to work towards absorbing early intervention and developmental services, that they decided they wanted to pull back. And so I've basically stepped out in June from this process of moving forward to honor where the Aging Disability Services Division wanted to move towards. And so I think it's a growth and development process.
Okay, so essentially suspending the original pilot.
Correct.
Okay.
And if I may, just one more comment with regard to, I think, the concerns about the state staff and why those frozen positions. If we go back to how a lot of this discussion has emerged from the April IFC, one of the only ways we were able to bail, so to speak, the Category 12 expenditure, we had exceeded authority. The program managers in my state program were allocating services to be provided to children to keep them off the wait list, but we had exceeded our authority. And so if I hadn't frozen state staff positions, I would not have had the money to move from Category 1 into Category 12, and we would have had to ask for supplemental funds. And so we are just trying to manage the budget with the resources we have in the entire 3208 budget account. And if we have a full complement of state staff, but we don't have enough providers to fund to provide services to the children on the IFSP, then we have a gross imbalance in the system. We're bringing families into the system, but we're not providing the services to them that are critical to their child getting improvement. So trying to freeze the state staff positions to fund the services that the Category 12 therapists provide was the rationale behind that. And it's the same situation today. We're fortunate that the Part C grant is going to be giving us more money, so I can unfreeze some of those positions in Category 1. But if I didn't have that Part C money, then I have to keep those positions frozen so I can move money from Category 1 to Category 12. Does that make sense? Thank you.
Any questions for the division?
Mr. Chairman, if I may.
Yes, let's go to Assemblywoman Carlton, who was graciously holding her questions from earlier.
And I'll hold on to those for a little bit longer until we get a bigger picture. I just want to go back to something that Ms. Wary had said. We were going through the letter of intent, and when I read that, it's about a rates study and how rates are paid. And it seems to me as though this letter of intent has grown a life of its own and turned into the systematic changes that we mentioned earlier. Is that my understanding? Is this where we're basing the foundation for these changes?
Thank you, Madam. I'm sorry, Assemblywoman Carlton. I'd like to step back to the sentence before that on page 17 where it says, in addition, the group should determine and document a reasonable methodology that will be consistently used to calculate the budget for caseload for the EIS program. So what we've been trying to do is develop a reasonable methodology so that if we get our caseload projections, we have a set of multipliers that we can use to tell the legislature if all the money that's available in the system is $25 million, for example, we can tell you exactly how many children that will serve. In the current system, I can't tell you that.
Okay, well, I don't want to get into back and forth, but the question was, we're using this basically, that was supposed to be a rate study to actually change the delivery service model so that the costs can be more accurately projected. Correct?
For the record, Mary Wary, we are trying to come up with a methodology to accurately calculate cost.
And that's through the delivery service model.
Correct.
All right. Which I think is taking a little latitude on that. I mean, when I see rate study and numbers, and I'm sitting in a Ways and Means Committee meeting, I'm looking at numbers, not policy. So it seems as though we've gotten into policy a little bit here, which, you know, I brought up earlier. Also, another statement was made through the explanation of this, something along the line of evaluating this so you wouldn't have to bring it back to the legislature, that you would get it all worked out and not have to bring it back to us, or did I misunderstand you?
Thank you. For the record, Mary Wary, if I understand your question, I think what I intended to say is that our goal of trying to meet this requirement to create a reasonable methodology for this budget was to come up with fixed costs and to run a pilot of that methodology as it affects the service delivery system, so that when we do our budget presentations next year, we could tell you with credibility that we had a high confidence level that this methodology was in fact the right thing to do for having a predictable budget and providing services to as many children as possible.
But we've changed that. It's no longer a pilot project from what I heard earlier.
Correct.
We're not calling it, but, so we're just making the changes,
You guys need to speak to that.
correct?
I'd have to defer that to Aging and Disability Services.
This is Mary Lavrati with the Division for Aging and Disability Services. Yes, that is correct, that we are moving towards providing a greater percentage of services through the community providers.
Okay. And that decision is totally based upon this rate study. Mr. Chairman, it goes back to the question that I had earlier. How did we
This is Mary
get
Lavrati.
here?
Again, for the record, that isn't based just on the rate study. That's been come out of a discussion of what should the state role be, and we want to move the role of the state into more of the monitoring, the quality assurance piece, and the role of our state workers, our developmental service workers, as being the ones that, again, have a more uniform intake system and assessment process, come up with the plan of care, and then have the direct service being provided by community providers. You know, the state will still be involved, but it's evolved out of a role of what should the state actually be doing and what should we be doing with our private providers in that public-private partnerships. We're still going to have a state workers involved in this. So all we're saying is that we're moving towards a system where most of the direct services will be provided through community providers. That being said, we know that we may have difficulty in providing or attracting enough providers, especially in the frontier and rural areas, where we think state staff or state contracted staff will have to be the ones that are providing those services. And in addition to that, as Mary talked about the specialty clinics, the state would still maintain that provision of service, is my understanding.
So,
Okay, and if I may, Mr. Chairman, I just had one quick follow-up. Ms. Wary had mentioned some meetings, and this was a consensus-driven decision. I'd like to know who was involved in the consensus, because I've received numerous emails from folks who are, I would not say, on the consensus side of this issue. So I'd like to understand who was in the decision-making process and how the consensus was driven, because apparently it's not universal. And of course it never is, but I'd kind of like to understand the genesis of this discussion.
Thank you, Assemblyman Carlton. This is Mary Wary for the record. Would it suffice if we send you the minutes from those two summits and the decisions that we arrived at?
Well, I mean, if you could just tell me, who in general, was involved, and I just want to have a feel for
Sure. Sorry.
where this came from, and I can grab minutes, I can get those things. I mean, and I plan on doing that.
I was
So.
going to say, a quick interjection for process. Yes, please, if we can have those for staff. But then if you could provide us with a quick summary to the Assemblywoman's question.
Sure. Mary, for the record, and Tina and Mary were there, so Jane can back me up, because I'm sure my memory will probably fail me in terms of everyone that was there, because it was a large group. We had several representatives from Parents Empowering Parents. Jan Crandy was there. We had the community representatives from all of the community partners. We had state staff from all three of the early intervention programs. We had representatives from the Part C program. We had representatives from the developmental services program, because ultimately the goal is to try and align these services to have a system that families don't have to navigate difficultly between when their child turns 3. We did not have anybody from the school district, because we've not ever had an issue on behalf of the children that we felt like they needed to be involved. We had representatives from NDALC were invited. I can't remember if they actually attended. We had representatives from the Interagency Coordinating Council. That's all that I'm coming up with. It was basically who we have come to know over the years as advocates or partners for this program.
Thank you, Mr. Chairman.
Okay, and I think before we move to Senator Kiefer has a question. Again, we're trying to figure out the storyline here and trying to understand. And obviously, one of the major things that we've uncovered is this back and forth between the two divisions, and there seems to be, starts and stops in different efforts. And so, this starts to become, I'm asking questions to the department now rather than the division. At some point, it was decided that, or it was acknowledged that this was going to be a significant change in model when we were talking where the health division was essentially the lead, and a decision was made, a discussion was conducted that we need to do some sort of a pilot to the ends that Ms. Wary described earlier, that we have to collect some information, we have to be able to prove the value of this model, et cetera, to the next legislature. That was suspended because of these meetings, and it was decided that we have to deal with this now, therefore we're just going to cut and move over and suspend the pilot program and just do this. I mean, I'm still trying to understand, from the legislative perspective, watching this take place in the interim, why was there any consideration given to let's hold off on the transfer? We're interested in this model. We want to look at this, but we have started an examination of simply, the value of the community provider model. Let's try to get through that process first, accumulate our information and our experience so that we can, provide information on that aspect of the program, and then perhaps enter into some sort of a pilot of looking at the streamlined delivery under which you're referring with aging and disability services. So that would be part one of my question. And then part two, picking up on something that was talked about earlier with concern about whether or not we've got provider capacity in the rurals and other areas. Legislators are always want to hear what the experience is in other states, and I'm sure, and I have heard from others as I've discussed this issue that in other states, this is how it's done. Well, as we like to think, and we truly are, this is a very unique state. I mean, we're the most urban of states with a massive rural territory. And so we are a much smaller state than many others. We are very unique in our challenges. What sort of survey has been done to try to benchmark against other peer states, if you will, that this is a model that, has been road tested in similar states?
This is Mary Liverati with the Aging and Disability Services Division. Regarding your first part of your question, I have to admit on our side we've felt the same way, that we haven't had a smooth handoff between our two divisions. But that being said, when the decision was made that we were supposed to start moving towards looking at the consolidation of disability services, what we were trying to do, coming from the aging and disability side, is sync it up with how we deliver services on our side, which is, if you look at our Medicaid waiver program, we have case managers who are responsible for that intake, that assessment, that developing the plan of care, the ongoing monitoring and quality assurance piece, and then we hand it off to service providers in the community. So, that's the model that we have in our division right now, and it just seemed, when we looked at the way the program works now under the health division, where we've got state employees, but we have contracted services that we're not even providing those direct therapies through state workers. We're contracting that all out. Maybe we should try to sync up those roles, because it has worked very successfully for us over on the aging and disability side. So I think that's where we said, wait a minute. And I have to be honest, I was really uncomfortable looking at trying to have a pilot, trying to build a budget for 2 years, and trying to figure out where we were going. We pilot services a lot, as far as, even with a new program, we don't call it a pilot, but we do start services. We were on our side more concerned with making sure that we could get the budget done and in by August, that we could then be looking at a phased in approach and implementing it, but going towards a system that we've already used on our side. So I think that's kind of where, and Tina, you can jump in here too, because she's our deputy over the programs, and probably you have some insights too. But from my own viewpoint, that's where I'm coming from, and knowing that the time was just so limited to try to decide how we were going forward. So that's my own perspective. And as far as the rural rates, Mary Wary probably is better to answer that.
Well, hold on that, because what I hear is the assumption was made that, well, this is similar enough to, if it walks like a duck, quacks like all that, similar enough to other service delivery obligations that you have, that you can just, apply that to the EIS space, if you will. But again, I guess what I wanted to hear was that, and we looked at what other states do, and we've evaluated that, and we find that this is consistent. I mean, is that the case? Can you, give us some details? Can you provide us with some assurance that that was done in a, sufficiently comprehensive fashion?
Thank you. For the record, this is Mary Wary. So state staff called around to a number of the other states, and I've picked the ones out of a lengthy list that are, I think, probably most similar to the state of Nevada. So Colorado does dedicated service coordination, which is what we're proposing. They have a staffing ratio of 1 to 50 in their urban areas and 1 to 40 in their rural areas for the service coordinators, and they have a public-private partnership. Montana does a blended role of service coordination and services. They have a public-private partnership. Their staffing ratio is 1 to 15. I think my perception is that in many of the smaller cities and rural areas, frontier areas, that the state staff are providing the services. New Mexico has dedicated service coordination, which is what we're proposing. They are 1 to 45 staffing ratio. They have a public-private partnership. Texas is dedicated service coordination. They have a 1 to 25 caseload ratio, and they have a public-private partnership. Utah is independent. They have a 1 to 24 caseload. They have a public-private partnership. And Wyoming has a 1 to 100 service caseload, and they have a public-private partnership. So I think
back to Utah real quick. Independent? What is it?
Yeah, they call theirs independent, and they provide the state provides the special instruction and the service coordination, versus the dedicated models where the state just does dedicated service coordination.
Okay.
And some of the variations, some states, I think part of what speaks to their caseload projection ratios and the variation from 1 to 15 to 1 to 100 is some of them do service coordination quarterly, some of them do it monthly, some of them do it weekly. But they're all regulated by the Part C program. When we did phase one of the rate study after we had the letter of intent from last session that showed that the state was more expensive than the private sector overall, one of the concerns that we had with the state is that we do more than just the IFSP services. So the phase two rate study really focused heavily on what are the costs associated with doing providing Part C services in the rural and frontier areas. And then the phase three rate study was really teasing out what are the costs associated with those non-Part C services, because in order for us to give you a methodology to build our budget to that letter of intent point, we needed to tease out these different factors so that we could accommodate the variations in the geographic landscape of Nevada, the needs of the children and the families, as well as that non-Part C component. So if you look at page 91 of the packet that Laura provided to you, the phase four, which is the one that was just completed, and from my perspective,
Hang on just
final.
1 second.
Sure.
I'm sorry, what was that page number again?
91.
Got it.
If we were to stay with today's model, where we're reimbursing the private sector $565, and I'd like to just reinforce that the phase one rate study resulted in a rate reduction to the private sector. When we testified last session, we had a blended, well, we had a specific rate of $659 for non-Medicaid children and a rate of $509 for Medicaid children, which just compounds the difficulty in projecting out the cost of this program. One of the things that we've seen with the economic recession has been that our caseload went for Medicaid children from about 33%. I think the all-time high we hit was about 47%. We're now somewhere around 40 to 42% of the children are on Medicaid. So it makes it harder. It's just one more mathematical equation you have to fold in when you've got a rate for Medicaid kids versus non-Medicaids. And the rationale behind that at the time was that the private sector could collect revenue from Medicaid to offset the cost, so that they shouldn't get the same $659 because they could generate revenue. And that's where we came up with the $509 rate. So what we tried to do was come up with a single rate, and that's where in November of 2011 we reduced the private sector, or kind of blended the two rates together to the $565. If you'll remember, the Part C requirements are that we cannot ask or require families to allow us to bill their private insurance companies. That's optional. Many states have worked around that by implementing a sliding fee scale and offering to families that we can either charge you the sliding fee scale or we can bill your insurance company, and if your insurance company pays, then we won't allocate the sliding fee scale rates to you. And so that's how many states have gotten to collecting more third-party revenue to decrease general fund. So if you look at this page 91, you can see if we stayed with this current rate that we would pay for providers serving rural. And the way I've come to define rural is the federal government, HRSA, has a definition of frontier, that any county that has less than 7 people per square mile constitutes a frontier county. So basically every county but Clark, Washoe, Douglas, Lyon, and Story, and Carson is a frontier county. So the way, and then anything that's in a metropolitan statistical area from our estimation constitutes urban. So we know that when you get up to Gerlach, for example, and Nixon, and you get to Overton and Mesquite and Logandale, places like that that are in urban counties, they're more expensive to provide services to because of the travel cost involved and the difficulty recruiting providers, et cetera. And there may only be one child. So you could be traveling for 4 hours to serve one child, 4 hours one way. So we have allocated zip codes to those rural definitions. So rural does not necessarily mean a county. It would for Douglas and Lyon and Story, But for those counties that are typically considered urban, we have zip code allocations where we would reimburse the private sector that $643 rate if they were going into those zip code areas. And part of our goal was to challenge the private sector to say, you know what, if you can do it cheaper than the state, then you need to look at the full service system and not cherry pick where you have high volume. Let's challenge the private sector to say, can you really provide it cheaper than the state, statewide? But let's come up with a rate differential that is fair to compensate them for each one of those unique landmass issues.
Okay, so while we're on that point, since you've done it by zip code, but you referenced Gerlach being rural as a zip code, do you have frontier zip codes as well? Do you have, or you just don't even bring that into to the
So
mix?
the frontiers are all those other counties other than the 5 I listed. So all other services being provided in those 12 counties would have a reimbursement rate of $751.
So if I'm in Gerlach, I'm getting 643, but if I'm in Lovelock, I'm getting 751?
Correct.
Oh, okay.
Because we use the federal definition of frontier.
Okay.
Haven't started it yet, right?
Yeah. But we have not implemented this rate yet because the private sector is
Sure.
not moving out to the rural frontier areas yet.
Yeah, okay, but so you acknowledge the limitation of that. I mean, it's, you know,
Absolutely. When I was the deputy at Medicaid, we had a rural rate differential for home health services. We had a 20% differential in the rate we reimbursed, specifically to cover the increased cost of transportation and recruitment of registered nurses to provide services in the home in those frontier areas.
okay, and so for those of you in Southern Nevada, it's the difference between, okay, Pahrump, I'm getting frontier,
Correct.
but if I'm Bunkerville, I get rural?
Correct.
Okay, that's... I know. No, but I mean, just this is a little bit of a rabbit hole, I realize, but I'm looking at this in terms of caseload, and I'm thinking of, the one kid in Bunkerville versus potentially 30, 40 kids in Pahrump. I mean, it's just one other.
It's about 5 in
Five. Okay. Probably shouldn't make any comments about that, but okay, great.
But that would be open for negotiation. We've always negotiated with the private sector because the important part is that we have a viable system. It's not going to serve us if we diminish the cost associated with these services to such an extent that we don't have viable providers. And part of the inability to control those Category 12 expenditures is in 2011, when we were fully funded by the legislature to reduce our wait list, we were having to go out and contract with speech therapy companies and paying them $145 an hour to provide the IFSP speech therapy service. So it's part of the conundrum of when you're leaving it up to the state, who doesn't pay enough in salary to recruit state staff to be the therapist, but we have to provide those IFSP services through contractors. The contractors start to be able to call the shots in terms of what they need to be reimbursed. We've been very blessed that we've got a number of providers who've been in this system for decades who have settled for a rate of $50.11 an hour to provide speech, language, PT, OT services. But they're becoming harder to find, and we found ourselves having to pay a much higher rate to try and get every single child off the IFSP, or off of the wait list. If a parent is not getting timely services, right now all these children on the wait list, the parent can go out and purchase those services that the state is not delivering, and we have no control over the cost of those services. So if they bring us an invoice for $200 for an hour of speech therapy, we have to pay it. So it becomes, again, the difficulty in trying to create a budget that has a methodology that is predictable and reasonable.
I was going to think of a few chairmen that would be far more. No. Do we have any questions from Southern Nevada at this break point on this section? Okay, no one rising. Senator Kiefer?
Thank you, Mr. Chairman. We've had a lot of detail. I want to get back to sort of where we are moving forward. And I want to state what I think is happening and then correct me if I'm wrong. You guys are working to put together a revised service delivery model that will be operated under ADSD that is going to require a couple of things. One, coming to the legislature in 2013 for with a BDR to actually move NEIS out of the health division into ADSD. So that's a place where I think a policy discussion would be able to take place on this, and then a funding request through your budget to allocate the majority of service delivery from category 1 and 2 into category 4, or 1 and 12 into 14. Is that correct?
This is Mary Liverati, for the record. As far as your first question,
Well, this is Mary Way for the record. There is no statute that we've been able to find that prescribes where early intervention resides or that early intervention is a mandate. The NAC 442 is the only regulation that I'm aware of that speaks to the health division as an oversight agency for the early intervention program in two areas. One, with regard to our ability to impose a sliding fee scale, and two, legislation that's occurred over the last two sessions specific to autism services, and the expectation that children, that the service delivery providers meet certain requirements, that children are screened with specific tools, et cetera. So to my knowledge, that's the only place that would be affected is in those regulations in 442. But I could be wrong.
this is Mary Liverati for the record again. Sorry, I had a blank in my head for a minute. We have requested a budget, a bill draft request, but Mary's right. There's no specific NRS that mentions early intervention services other than the screening for autism. We have a bill that is a companion to the budget to bring not only early intervention services but developmental services over, and actually we have some NRS regarding the developmental services that is in that bill request. So.
We're going to look at that because I think there's some question as to, there may not be an express, statute that you're concerned about, but there may be some references to the division that we need to make sure are cleaned up. So there may need to be a housekeeping bill for that.
And we have requested a budget BDR.
Okay. So we're going to hear more shortly on that one.
Mr. Chairman, if Senator Kickheffer is finished.
Yes, please.
Thank you, Mr. Chairman. Going back to the procedures and the evolution of this whole thing, I go back in my memory to 2007, and there was a bill draft from Senator Warren Hardy at the time, and I've gone back and looked at the bill draft just very, very quickly. I'll have to do a little more in-depth work on it. But it actually proposed, I believe, some of the things that we're hearing about now. That bill draft did not pass the legislature. It did have very robust discussion and did not go forward. I think in the light of that policy discussion at that time, and now we are still moving forward with something that the legislature had concerns about then, I just still have concerns that we're moving in a direction without having all parties heard from and all issues addressed. I know there are a number of concerns about how people are paid and the rates that are charged, and we just heard a very quick overview of the differences there. But I mean, I have concerns that the state is responsible at a much higher level than some of the community providers are responsible at. They only take as many children as they can serve, which is the way it should be. If they can't take 120 children, but they can serve 100 well, then yes, they should be taking that. But the state is the fallback. We are the safety net. And if this program changes as dramatically as I'm envisioning and has been discussed, I'm afraid there will be no safety net for the children. And that is, and especially in the frontier or rural areas where we always know that it's hard to get services. So I still have that overarching concern. I appreciate the community providers, for-profit and nonprofit. They do an excellent job. I've worked with a number of them when I spent my short time in the nonprofit world. And if you think public service is tough and the nonprofit world is 10 times tougher, I mean, they are in it, in the trenches, doing the job that needs to be done for these children, and I greatly appreciate them. So I don't want anyone to think that, you know, this is a disparagement against them at all. I just want to make sure that we set up a process that makes sure that all children get served. And I have concerns with eliminating the state's portion of responsibility as far as the safety net for these children. And the fact that we're moving forward on a program that had previous discussion in a previous legislature and had numerous concerns, and I don't think those concerns have been addressed. So thank you, Mr. Chairman.
I believe we would like, happy to entertain the response, please.
Mary Worry for the record. Thank you, Assemblyman Carlton. I think what we've been responding to is how the last several budgets were approved. For the 2009 and 2011 session, the legislature made it very clear that any new dollars that were put to the program were to go to the private sector. And so I wasn't a part of the 2007 discussion, and I apologize that I don't have that history to speak to, but we
Mr. Chairman, excuse me. Could you please repeat what you just said? I'm sorry, I was looking at something, and I just want to make sure that I heard you correctly. If we could go back and if you could repeat that, please.
Sure. Mary Worry for the record. Assemblywoman Carlton, I apologize. I didn't start with the division until May of 2008, so I don't have that history from 2007. But we have, in the 2009 and 2011 session, the legislature made it very clear in the money committees that any new dollars that they were giving to this program, and they were significant, were to go to the private sector. So that was a part of our presumption that we were continuing to embed and strengthen the private sector delivery system. And in terms of, I totally appreciate your concerns about the frontier area and the state being the safety net provider, and I had discussions with a number of leaders during the last session about their concern about the state being the safety net. And so part of that pilot model was that if the state was providing service coordination, that's the only service that is mandated by Part C. If we're going to have a Part C program, a grant, we have to provide service coordination to 100% of these children. That's not an optional IFSP service. And so the state has currently been contracting for all of our IFSP services other than the service coordination and specialized instruction, which have been provided by the same staff person, the developmental service specialist. So our rationale was that if for some reason the private sector did fail, that we were trying to find a way to accommodate the entire legislative body concern that we had heard, grow the private sector, but state be the safety net. And so the service coordinators keeping those developmental service specialists in Category 1 would allow us to then, if the system failed, to go back out and contract, as we have been, for all the other IFSP services, regardless of the region of the state. So that was the logic behind that. Now, some will tell you there is a cost to that. So it is more expensive for the state to keep a dog in the fight, if you will, for that service coordination piece. If we were to just transition out 100% of the services, the service coordination and everything else to the private sector, we could keep the rate of $565. But then we don't have that safety net component that has a price tag attached to it. So I don't mean to use language that may be offensive to anybody, but that's just the bottom line of what our logic and rationale was for why we were building the pilot the way we were. Does that help?
Mr. Chairman, if I may, I only sat on in our Ways and Means for the one session, and I do remember the discussion, and I guess I should go back and pull the minutes to double check for my memory's sake, but I don't remember ever talking about eliminating these drastic of changes. The discussion that I remember was, we have children on a wait list. They are not being served. We cannot get enough state folks to do this. We need to involve the community in serving these children. I don't remember there ever being a discussion about a total systematic sea change on how the service delivery model was going to work in this state. And that, as I said earlier, this seems to have just evolved past just getting services to children. And if I'm wrong, I'll be happy to be corrected, but that's my recollection. Our whole goal was to make sure children got served. And there are community providers out there, for-profit and non-profit, that can do this. But the state should not be abdicating its position in providing services. So I think that's been the biggest confusion in this whole discussion. And if this discussion had happened at the legislature and everything had been aired and all parties would have been allowed to participate in the discussion, I don't think we'd be in this position today.
Okay. Trying to get back onto our schedule and progress here. At this point, would that constitute the totality of your presentation? Okay. Just want to make sure we got everybody.
For the record, this is Tina Gerber-Wynn. I think the more we try and clarify, the more we learn in this discussion. I would say the state will provide direct services for children when it's necessary. And the amount and percentage, people get caught up in that. We don't know for sure what that's going to be because we're not sure what children's needs are going to be when they enter the program. We discuss about what the community providers do. They will provide direct services, and they have for the past 4 years successfully. What we're talking about is internally whether we maintain direct service responsibility for all the kids that are in the system or part. And we always have to case manage every single one. The state will not give that up. We have to figure out where we then pass on and communicate directly to the providers to start the care. So the service coordination piece is the part we retain to assure that we're meeting the requirements and serving children and monitoring the whole population consistently. And then the community providers would have some role in coordinating the services too, and that's what we've been discussing in these meetings. But the state would not always be in the best position to respond directly to those plans of care. That's why the community providers are available. They can gear up quickly and provide the care. Whereas in some areas we don't have staff. We've had shortages, as Mary Wary has described, where we don't have therapists, but the community providers do. So that's the flexibility we're trying to build into the system, but we as a state retain the responsibility to assure kids get into the system quickly, are assessed, and have services accessible to them. So we aren't giving that responsibility away. It's not necessary and it's not part of the plan. But I do think it's communication, and that next step on page 8 that we talked about was really clearly delineating our transition planning, our thought about what the pilot, quote unquote, was to uncover as far as moving children from intake into the community providers for direct service delivery or staying with the state for direct service delivery, depending on the area of the state the children were in. So those kind of things are what we were trying to finalize in our transition planning. And if there's areas that we need to clearly document so that it is consistently communicated, definitely we agree we need to do that. That was part of our number 1 bullet on page 8. And then, again, finalizing the rates. And we described several scenarios that obviously people are saying it could work or there's problems, depending on the zip code or the amount, etc. And those are definitely complex issues that we know we need to vet and describe so people can react to them.
I want to shift a little bit to this idea of Part C compliance and what's in, what's out, and you'll just have to understand that I think a major concern for the Interim Finance Committee is, we left session with one understanding of how we were going to deal with this, and then we figured out that bringing folks into the clinical setting was not going to be allowable. And so now we're examining this new model. What has been the conversation with the feds, with the Department of Education, in terms of their review, their monitoring of our program? What feedback have we gotten from them? What guidance, if any, have we gotten from them? Could you just describe, and probably the more obvious point of contact would be in some sort of an audit or something like that. And I don't know if anything like that has happened, but even just beyond that, I mean, not resting just with that, but, conversations, guidance, instructional, memoranda, whatever.
This is Mary Liverati, for the record. I attended a meeting back in Washington, D.C. in May of this year, which actually was dealing with many early childhood issues. But the Office of Special Education Programs was there, specifically the person that oversaw the Part C office. And one of the things that I found really interesting in her discussion with us was that we have looked, when we talk compliance, we think meeting these, the 30 days, the 45 days and those things. What she said to all of us is, on the federal government level, they are moving towards looking at outcomes first. So, we can be in compliance and not having the outcomes that we need to have for these children. So on the federal level, they are going to start looking more specifically at outcomes. And again, not saying that compliance isn't important, but instead of coming towards compliance first, they're actually going to look at outcomes first. And that's one of the things when we talk about quality assurance, we also want to make sure, because we can be in compliance 100%. If we're not getting the outcomes we need for our children, we're failing them. So it's a kind of changing the thinking on the federal level. It'll trickle down to the states. We've actually got a staff member that's at a conference this week, and one of the big discussion points was outcomes, and we're looking forward to her coming back and sharing the information that she's learning right now. So I think, that's a different way of thinking of it, because when we look at we do every year an APR, which I'll try to remember, it's annual performance review, and there are outcomes in there. But a lot of times we even focus on the compliance issues and we're not really looking at the outcomes. How successful are we in it? It's got many good indicators about, are we moving children to where they are getting to the point of typically developing children? Because we want to make sure these children are ready for school and that they have language development and they're ready to learn. So, I just think that that's something that is a little different than we've looked at in the past. And so on the aging and disability side with the Part C office, that's one thing that I've been talking to our staff with for the last 4 or 5 months, that we need to be more outcome driven. We need to look at those outcomes, because whether you're in compliance or not, if we don't get those outcomes right, we're failing these children. So that's the first thing I would say, and that we will have more information, like I said, coming from this conference and this just being held this week. Regarding compliance is important to us, though. I don't want you to think that I don't think that is important. But, we seem to look at this program in segments. We really need to look at an integrated approach to the whole thing, and we sometimes don't look holistic at it. We on the Part C side, and I'll let Mary talk about the actual health division side of it, but we, I feel, haven't done or lived up to our potential under the Part C office. We haven't been bringing in enough technical assistance to help our state. We haven't been looking at what other states are doing and moving forward and what their systems are and how we can improve our systems by bringing in more of that technical assistance. And we have a great resource where they've got technical assistance centers that cost us nothing to bring them in to provide that to our state. And so, we've got to look at our own staff roles, whether there's any changes or not. The Part C office is going to try to start looking at changing the way we do business, I think. So, Mary, you want to talk about health?
For the record, Mary Wary, I think I've testified to this a number of times. One of my big ethical concerns has been with this program that there seems to be historically more of a value on where the service is being provided instead of the service being provided timely. And as a clinician, I believe that there's a balance to that, and I think that speaks to what Mary was describing with regard to what's the core infrastructure that we need to have in order to make sure that children have what they need to successfully grow and develop. And I'm not undermining the natural environment concept, but there's a big price tag attached to that natural environment. I don't know whether Part C has tracked this data, but I think it would be interesting for them to look at how states may be serving natural environment with the economic recession, because every state has been faced with having to figure out how to do more with less. And so you have to figure out ways to cut corners and to find compromises in order to be able to do that. So I personally don't have a problem with finding that balance. I do believe there are some services that need to be provided in the natural environment. I absolutely believe that there are a number of children who need to have their services provided in the home. They're medically compromised, they're fragile, and it's not appropriate. There are families who absolutely can't do the transportation. But then there are other families who take their children into the community on a regular basis. They take their children to clinics for other services. They take other children in their family to the clinic to receive their services. And I think, quite frankly, that's a little more normalizing than having this one child separated out from their siblings. But that's just my philosophy. So I again, have had to struggle with, in terms of managing the dollars in the budget, do we get kids off the wait list and provide services in a different model? Or do we continue to provide services the way we always have and keep kids on the wait list? We've been under needs assistance by Part C program for that wait list. For I don't know how many years, we have been non-compliant with the wait list. So our approach was to get the kids off the wait list and compromise the environment.
This is Mary Liverati again. I would say again, that's where technical assistance would have been so appropriate, that we had gone into this changeover, because we experience families that don't want you coming in their home for a variety of reasons and are more comfortable coming into a clinic. So I think that with technical assistance, it's not that you can't serve children in a clinic, but you have to give parents a choice. And you have to, there's other natural environments that are out there that are communal or community settings that, again, I don't think we could have done a better job bringing in more technical assistance to have looked at changing and going to the clinical model setting. The other thing I wanted to say in response to your question about audits is that we were expecting to have a program review this year. They were supposed to come in August. They called and postponed it. And then we were told that the federal government has suspended those for this fiscal year, so we will not have a program review. We did have a fiscal monitoring, is what they call it, not an audit. They conducted it over the phone with us over materials that we had sent to them, but we have not received any written report yet, and we'd be happy to share that with you when we get that from the federal government. But and then, like I said, we do the annual performance review every year, which is quite a lengthy report. The report must be about 35 pages, which goes through all the indicators and the compliance issues, and then the feds usually call us back to go through that report with us. So if you would like any copies of any of those things, we're happy to provide those.
Okay, so the special review was postponed?
It wasn't a special review. It was a programmatic, what they call, let's see, what are they? Program evaluation is what they call it. They were due to come in August of this year.
Right.
They called and postponed it, and now it's been postponed through this fiscal year. So
Were reasons given
federal
for
government
why?
just suspended it. I'm not sure. I mean, it may be that if they're going to looking at outcomes more, maybe they want to look at their monitoring tools and to make sure that they're changing their review process. But as they are not coming to do that review, which we had been told they would.
Okay, so that's just conjecture as to why at this point.
Right. I don't know why. It could be a money thing. They don't want to travel out to states. So.
Sure. Okay. All right. Do we have any other questions at this point? Anyone down south?
Mr. Chairman, if I may, one quick one that I missed earlier in a bit of confusion, Ms. Wary, when we were talking about the vacancies, and I know that's been a big issue with the Interim Finance Committee, is the vacancy savings. The move of the $200,000 from the one category, which I believe was the state employee portion, the vacancy savings, to, I think it was category 12 for state contracts. Is that correct, Ms. Wary? Did I hear you correctly?
Thank you. For the record, Assemblyman Carlton, that's correct. Last April, I think it kind of started this dialogue. We did the work program moving Category 1 expenditures into Category 12 to cover our over expenditure of contract dollars, and we did generate additional Medicaid revenue with targeted case management. So that's what funded that work program. And Aging and the Health Division are working on a work program for December that will do basically the same thing. I will be able to unfreeze some of these positions in Category 1, since we've just found out that we'll be able to get additional Part C carry forward funds that will help reduce our Category 12 over expenditures, projected over expenditures. So as long as I know we have enough money in the budget to not exceed authority, we'll unfreeze positions. But as long as we were exceeding authority, on track to exceed authority, we felt it was prudent through people leaving the program to freeze those positions so that we could cover our costs.
And that was for the contracted cost. So, Mr. Chairman, would it be okay if I ask a couple of quick questions on the contracted rate
Please continue.
section? Okay, thank you. I want to make sure that I understand how the billing is handled. If a child is referred to a state contractor, your Category 12 division, how does that contractor bill the state? Is it per diem, by service, by month, billable charges? How is that rate negotiated?
Thank you, Madam Assemblywoman Carlton. For the record, Mary Wary, that's a very good question, and that's one of the reasons why this budget's been so time-consuming and difficult to manage. Fundamentally, what the state has done for a number of years has used the provider agreement to contract and the Avision contract to contract with therapists, and we pay those at an hourly rate. But we could not recruit enough Avision contractors in order to maintain that model. So in 2010 and 11, where the legislature's goal was for us to reduce the wait list to 0, we had to develop provider agreements with speech and therapy companies, and we basically have had to negotiate with them what they were willing to settle for each IFSP service. Sometimes that was an hourly rate, sometimes that would just be, well, I guess it would be the same thing, per service. And so the range could be anywhere from $75 an hour to $145 per service. Some services can take an hour.
And Ms. Wary, I hate to
take 2 hours.
Ms. Wary, if I may interrupt you, just because there's a learning curve here for me, and I want to make sure I'm understanding. We're specifically talking about Category 12 right now. We're not talking about the community providers. That would be a separate rate structure. Am I correct?
Correct. The community partners,
good.
we pay a fixed rate. Category 12 is not a fixed rate. When we are paying the Avision contract, we have a negotiated fixed rate. But when we're individually negotiating with non-Avision contractors through provider agreements to try and get those services provided, those are not fixed rates.
All right. And if I may, we can switch to the community providers. The fixed rate, is that a daily rate? Does it have augments to it? Let's say a child needs something special. Is it daily plus expenses or whatever, or is it just this is how much you get every day you give service to the child.
Thank you. For the record, Assemblyman Carlton, the Category 14 expenditures are all at a fixed monthly capitated rate of $565. So whether a child needs 2 or 3 IFSP services, including service coordination, or whether they need 10 per month, they get $565. That $565 also includes the private sector working, so to speak, the referral. So you're probably very familiar with the waivers where we talk about slots. So we've basically taken Category 14 dollars, we've divided it by 12, and divided it by 565, and that's how many children we know we can serve that month using the private sector. It's a fixed cost. So that includes from the time we refer out to the maximum number of slots that we have for that month. The private sector may work a child up, which is a pretty labor-intensive, costly process. They use their service coordination, developmental specialist, specialized instructor. They may use a PT, an ST, an OT, or a combination of those to determine, is this child eligible for the EI program? 60% of the time, those children are eligible. 40% of the time, those children are not. So that $565 includes the cost that they absorb for trying to determine whether the child is qualified for the program or not. It also considers their administrative costs. It's just a flat rate that we pay them for 100% of everything that they do, regardless of the level of intensity.
So if they get a monthly rate, but they only have a child for 2 weeks out of the month, they get the same rate?
Correct, because they may have had 25 referrals that they worked in that two-week period, and only 10 of them resulted in an IFSP. So they're not going to get paid for the work they did with those 15 children that didn't get an IFSP. They're only going to get paid for the children that actually got an IFSP.
I have concerns about that. It seems as though we're paying for a full month for services for children when they're only there for a portion of that month. I mean, literally, if the service is dated, for 1 day out of a month, they could be reimbursed for that whole month. So I have some concerns about that, and I understand, but yet this is negotiated. They have sat down with you and said, okay, per child, these are the services. It's a wraparound model where they're going to do whatever it takes to take care of that child. But because we're paying them on a monthly structure, I mean, if they pick the child up on the last day of the month, they literally get paid for the whole previous month.
But they
to me, that seems like when we're trying to balance dollars, especially when we're moving dollars around to make sure we have service monies, that we would want to look at, is that the most effective way to be paying a provider?
Thank you. And this is basically the same way that Medicaid works with their managed care plans. A child may become eligible on the 20th of the month, and the managed care plan is going to receive a capitation rate for that child for the entire month. And to your point, that child, I mean, it's the possibility that a child comes on for 1 day of service is real. On the other hand, the possibility that they've done 25 assessments that month that led to not one IFSP and therefore no reimbursement is also real. And the possibility that they've had a child with autism who needs an excessive amount of intensive behavioral services is real. But they're not getting any more than that $565 for those children, regardless of the intensity of service needs that they have. So I understand we're just using a model that has been working for probably 40 years in the healthcare industry.
Well, but things are changing. I guess what I would probably need to get a level of comfort with this is to actually look at some of the numbers, the data on, folks being paid for a monthly service when the child was possibly there for let's say less than half the month, let's just split the difference, less than 15 days, but getting paid for the whole month. I'd want to make sure that we haven't set up a system that people have figured out how to use to their benefit. We never make the rules for the good guys. We only make the rules for the bad guys and who will abuse the system. And that ends up giving even the good guys, a bad name. So I would want to make sure, even though we've done it the same way for 40 years, maybe it's time to take a look at, should we actually be paying them for the assessments that they do? I mean, if they're putting time and effort on the ground serving these children, maybe we need to readjust the rate schedule to make sure that, we're not asking a nonprofit to absorb services that they're not being reimbursed for. I mean, they're living on the edge also, the same way we are. So I just have concerns on both sides that this fixed rate is not really serving either the state or the nonprofit providers who are playing by the rules. Thank you, Mr. Chairman.
And if I may, I did include in the work order for this contract or strategic progress, I allocated 10 hours for the private sector or the legislature to access her. We tried to respect the private sector's concern about divulging all of their financial information to the state. And that's why we hired Strategic Progress to do these rate analyses. And so that is available to the legislature if they would like to access that, so they can understand exactly how they used the cost for the private sector, the IFSP information they were able to get from the track system to come up with that rate of $565.
Yes, please.
Senator Parks has a question.
Senator Parks.
Thank you, Mr. Chair. I was just going to say that I'd like to see that information regarding strategic progress. Thank you.
Yes, duly noted. Okay. We hope that you stand by. We may feel the need to bring you back up. This is one of those situations where the questions just keep flowing and flowing and flowing, and it's our job today to just take in as much information as we can and then report back to the full IFC our findings. So with that, we may be bringing it back up. So don't stray too long or too far. And I understand that we have a number of doctors with us today in Carson City who have expressed a need to be back in Reno by 1 o'clock, and we certainly don't want to prevent them from seeing patients, because that is super important. So I am just going to go through the list and try to discern who those folks are, and I'm just calling the folks that have indicated that they wish to testify on the sign-in sheet. And I was negligent at the outset to let everyone know, if you do wish to testify wherever you are in our network of 3 locations, please sign your sign-in sheet and mark if you wish to testify on this item. And we'll start in Carson City, and then we'll go down to Las Vegas. So with that, I would like to start with the doctors, and I'm just going to call the names. Please, to the extent that you can, avoid being repetitive in your testimony. And I'm sure that you have all discussed your batting order for the day. Pardon the baseball metaphors. We have Dr. Rodriguez. What's that? Yes. Dr. Sabathia. We have Dr. Rodriguez, Dr. Coletti, Dr. Hendrickson. Senator Kiefer is going to pay for that. Good morning and welcome, and thank you for taking time out of your morning to join us and provide your perspectives.
Thank you for letting us speak. I'm Dr. Deborah Hendrickson from Reno. This is Dr. Gerardo Rodriguez, who's a pediatric neurologist from Reno, and Dr. Pat Coletti, who's been a pediatrician in Reno for many years. Fantastic.
And if you could, as you progress from one to the next, just for the sake of our record, be sure to identify yourself each time you begin speaking. Thank you.
Okay. I just wanted to say we're here on behalf of not only ourselves, but on behalf of 40 pediatricians and pediatric subspecialists who added their names to the letter which we submitted to the committee. That basically represents the entire pediatric community in Northern Nevada, which strongly opposes this proposal, and that's why we've come down here today. And we didn't even contact the family practice physicians. We probably could have gotten 20 more signatures on that letter had we tried. So Dr. Coletti is going to go through some background, and then we're going to each go through our specific objections. Pat?
Good morning, and thanks for letting me come down. I'm Pat Coletti. I'm a pediatrician. I'm a native of Virginia City. So Gerardo told me I had to tell you guys that, but don't hold it against me. I've been a pediatrician in Reno since I got out of the Navy as a pediatrician in 1983, but my experience with what was first called Special Children's Clinic and now NEIS actually began in 1971 when as a first-year medical student I spent many hours there with Dr. Tom Scully, our dean, who was also a pediatrician. It was my introduction to pediatrics actually in general, and one of the reasons that led to my choice as children's health as my career. When I returned to Reno, I became actively involved with both patient referral and in the early days the actual evaluation of children at the clinic. In those years it took the community pediatricians would go and spend their time to try and help the evaluations there because we did not have really a certified developmental pediatrician to help us with all of these special needs kids. We got by, but it was led to a lot of out-of-state referrals sometimes, and we really struggled hard to find a developmental pediatrician for the community that could service these children. And as these care needs, about 15 years ago, we welcomed Dr. Kimmen as a board-certified developmental pediatrician to take over the services of these kids, and then we became her referral source. A lot of people have been talking about all these kids that get referred to special services, and I wanted to reinforce to you guys that about 95% of them have a primary medical home in the community, and that we are usually the primary referrers. The schools and churches and other places that moms sometimes hear about going to NEIS are a marked minority compared to the physician direct referral. And that includes the subspecialist, which Dr. Rodriguez will talk to you about. As a medical home for these patients, we are obligated and need someone who can not only completely evaluate the patient, but be able to effectively communicate back to us their needs and their ongoing treatment plans so that we can stay involved. Dr. Kimmen has done this magnificently over the years, when we started in 2007 of getting other community physicians involved, we found immediately that there was a decrease in our communication on our patients because a lot of the other community resources do not necessarily complete the circuit and get the information back to the medical home. That's been a big problem we've worked under, and it continues. I was also surprised and somewhat disappointed that NEIS was changed from a true health division to a disability division entity because this is health care. The work that goes on at that division at NEIS is the evaluation of the patients, the instruction a lot of times of medical students in the care and the medical teaching of those patients, the referral back to the primary physician, all done on some of the hardest to take care of kids in the state. This is true medical care, and I'm sure the other pediatricians share my concerns that if this entity becomes the stepchild of disability, it'll just we always worry about the kids just being referred to as the little people, and their importance and needs could be diminished by being put into a large group of disabled adults. Dr. Hendrickson is going to discuss some of the other money and budget issues, but I would like to make a comment about some of the money. When the state started cutting back on budget, NEIS was the first one to take the hit. and they lost 50% of their budget over actually 1 year's time. However, they continued to provide exemplary service considering the fact that they were totally understaffed, and I wanted to commend them for maintaining their communication with us even though they had little time and little personnel to do so. In the eyes of the practicing pediatrician, this is my take. We have a wonderful board-certified developmental pediatrician who has the knowledge and does the work that we have absolute confidence in. She effectively communicates the patient's needs back to us, and this is the medical home. She supervises an effective staff that actually performs many therapies that are unavailable elsewhere in the community, and can also evaluate a wide range of healthcare issues that other entities cannot do, and that's because she has a background of being a generalist in pediatrics, and she can spot sometimes medical conditions that some of the more specialized people like speech therapists alone are not aware of. So many of these conditions, especially with the help of the pediatric subspecialists in the communities who also have complete confidence in their abilities, help us establish early and effective treatment for these children. NEIS is doing this on a budget that's been quite constrained over the last several years, and I think they've done a wonderful job. We do have a concern with going out to the community. We don't have a problem with their actual work. We do have a problem with the problem that I just discussed with their communication back to the medical home. It seems like everyone wants to carve it up. We have all these pieces, but no one realizes that the primary responsibility comes back to the medical home in the situation. So we have been questioning that need. The other thing is that there is one way, as we're talking about doing some remodeling of NEIS rather than taking it out of business entirely. NEIS actually is in a perfect role, being here in the community for over 40 years, to be the quarterback of all of the other entities that then would participate in the care of children under that guideline. So NEIS could actually assume a larger role and become the guideline supervisor for these other subspecialists, as in speech therapy and PT, OT, and the things, who would love to have one physician, a communication source to get back to on any of the kids that they see. That's pretty much all I have, and I appreciate your time.
Thank you. And I think what we'll do is, if we can hear the full panel presentation, we'll undoubtedly have some follow-up questions, and we'll proceed, and then we'll go to those questions. Thank you. We can't hold the question until you have a comment to make. Oh, yes, please.
Thank you, Mr. Chairman. Before we proceed, I just want to disclose that Dr. Hendrickson is my kid's pediatrician. And I think if this says anything about what we've been doing over the past 6 years, I think my kids have seen about a third to a half of the physicians on this list. So, for what it's worth, thank you, sir.
And thank you for that. And for what it's worth, I'm in the same position, not with the specific people at the table, but certainly on this list. And you can better believe I checked the list. So, yeah.
This is Dr. Hendrickson again. I forgot to mention, too, that we asked Dr. Kinman to attend the meeting with us. She's in the audience just because she works not only with NEIS but with all the community providers, and she's very fluent on the differences and capabilities of the different providers. So if you had any specific questions about that, she's a very good person to ask.
Thank you. Appreciate that.
Okay. I just wanted to go over, if you've read the letter, you know that we had some fairly specific and detailed objections, and there's a reason why so many physicians have joined the letter and joined our objection to privatizing NEIS. But I wanted to just go over the summary we put together, which includes a few additional points, and I hope you have that as well. As Dr. Coletti was saying, the main reason you're seeing this outcry from the medical community over this proposal is that we feel our patients get superior care at NEIS. They've been getting that care for decades, and we highly value and trust the expertise that's in that building, most notably Dr. Kinman, but the whole team she works with. And all of us, I went to the med school at UNR. I trained up there with Dr. Kinman for a month. It's just an amazing facility where there are all these specialists right there. If you need someone's help or input, they can be pulled in. And that kind of centralized, integrated team care delivers better results and better continuity of care for these chronically ill, disabled, and delayed children and their families. And there are studies that show that that kind of model works best for these kids. And as was mentioned earlier this morning, it's that type of wraparound care that's strongly encouraged by Part C of the Individuals with Disabilities Education Act, which is the act that mandates early intervention services in every state. But I think there's a number of very specific impacts this proposal would have to these kids and to the medical community in Reno and Sparks that has not been considered, or maybe the administration or the legislature is not aware of. The first is privatization would endanger our hospital's level 3 NICU status. So right now we have level 3 NICUs in Reno, which means that we can take care of the real preemie babies, the babies that are very medically complicated. But you must have follow-up care for those babies, of a certain quality. And right now, NEIS provides that follow-up care. If we lose NEIS, we could lose our Level 3 certification, and any baby born needing that care would have to be transported out of town. So a family would not only have to deal with the sick infant, but with uprooting their lives and going to Sacramento or the Bay Area or wherever. The other impact on the NICU would be that the loss of the feeding therapists who come in from NEIS into the NICU and help the preemies and the other medically fragile babies learn how to feed and self-soothe themselves is a really vital resource we have right now that is lowering the G-tube rate in Reno to 40% below that we see in Las Vegas. The G-tube, of course, is a tube that goes through the abdomen and avoids having to go over it. Yeah, okay. And that's significant, and a lot of these kids are Medicaid kids, so that would be an expense that would likely increase for the state if we lose those feeding therapists. The state could lose over $500,000 in federal grant funding under the LEND program, the Leaders in Education and Neurodevelopmental Disabilities program. And under that grant, NEIS is a central player, a key player, and if we change the terms of the grant, we could lose $550,000 in grant funding. As Dr. Coletti alluded to, we would lose a vital site for training our future physicians, nurse practitioners, and other healthcare providers such as speech therapists and physical therapists. The med school relies on NEIS to train a lot of physicians in this type of work, especially physicians who are interested in being pediatricians. The state would lose the CAPTA program, the Child Abuse Prevention and Treatment program that is currently administered through NEIS, which evaluates and provides therapies for young abuse and neglect victims who are children who have very high risk of developmental delays. We would lose the urgent feeding team that treats infants with major feeding issues within 24 hours of a pediatrician's referral, often avoiding costly hospital admissions. We would lose the only trained experts in northern Nevada dealing with a multitude of specific hearing, vision, and speech issues found in delayed and medically fragile children. And we believe that long-term Medicaid costs will likely be higher if these children do not receive the level of care they need during important developmental periods. As I referenced in my letter, there are critical windows of development within those first 3 years, and the kids have to receive the services within those windows of opportunity, or you can lose the possibility of ever bringing them up to their full potential. And it's, this is maybe a little bit of an editorial comment, but it appears to us in looking at this that NEIS was set up to fail by the budget decisions that have been made in the last 2 years. And I'm just referring to northern Nevada numbers here that that are publicly available, so you can correct us if we're off here, but it looks like in 2011, NEIS served 874 children, and they had a budget of $1.9 million for contractors, a total budget for all their staff of $2.65 million, and they had no waiting list in northern Nevada that year. The next year, the contractor's budget was cut in half, and in 2013, it's going to be cut again. With less funding and unable to fill the vacant positions they have because of the hiring freeze that's been targeted just at them, obviously the wait time has grown. Now that wait time, it appears to us, is being used as a justification for dismantling this agency that we all rely on. If Easter Seals, for example, saw that same number of kids at the agreed upon capitated rate of $565 per child per month, the total would have come to $5.9 million a year. So it's just hard for us to understand why the budget is being used as a reason to make this change. And we have the same concern that the Assemblywoman from Southern Nevada mentioned about the incentives lining up in a way that, someone can accept the child in 1 month and not see them for a couple of months and still get the same rate per month, and that is a concern we have as well. And just finally, I just wanted to say that, Nevada already ranks at the bottom of all states in measures of children's health care accessibility. We have the fewest kids who have a medical home. We have one of the highest rates of uninsured children in the country. Fragmentation of NEIS's current role would lead to even more kids, we believe, getting lost and neglected in the system. It would lead to financial competition between providers and a focus on the bottom line instead of collaboration in pursuit of the child's best interest. It's really inexplicable and inexcusable to us for no budgetary gain that we can see that the state is gambling with the welfare of our most fragile and neediest citizens, our patients. So with that, Dr. Rodriguez.
Thank you for the opportunity for public comment. My name is Gerardo Rodriguez. I am a pediatric neurologist and I have been in Reno since 1990. I worked as a general pediatrician for a number of years and also as a pediatric neurologist. And for a period of time, I also worked as a contractor for the rural arm of Nevada Early Intervention Services that at the time was called HAPPY program in communities including Elko, Ely, Hathorne, Battle Mountain, Winnemucca, Fallon, Fernley, Yerington, and other towns. I served in that position for 12 years, 1 day per month. So I have the perspective of having worked in the trenches as well as being a unrelated provider who refers patients to Nevada Early Intervention Services. The care that my patients and their families have received from early intervention services has been of paramount importance. And I share the sentiments of Dr. Hendrickson's and Dr. Coletti's words when I tell you that I admire and I thank for the services that I have been able to receive through my patients and their families. Many of these children have become caught up in their development and are now productive adults. Many of my patients that have gone to Nevada Early Intervention Services are now high school graduates. They've gone to the military, they're in college, they're working. And some that are less fortunate and that have remained disabled, their lives have been enriched and their lives in some instances have been saved by medical interventions from NEIS. And in other instances, they are doing a lot better because of the help that they received. And when I worked in the rural area, I can give you a first-person account of working with a very talented and dedicated number of people. These professionals that work primarily out of Elko and that travel from here to the rural communities are dedicated, are ethical, and they give their all to go out there and give the children the services that they require. Another perspective that I want to share with you is that if we lose Nevada Early Intervention Services as an umbrella organization, I feel that not having a coordinated early childhood program will make it very difficult for us to attract and retain pediatricians, developmental therapists, and pediatrics as specialties to our area. It is already a big challenge for us to have pediatricians and specialists in Northern Nevada. And not only from the physicians and professional side, but I sometimes see families thinking very hard about whether to relocate to our area, depending on the services that their children can receive. And unfortunately, sometimes families do relocate out of the area and we lose valuable talent in the education and business areas because their children need services that we don't provide. And if our services are further curtailed, we're going to lose more talent than we already do. Thank you for your time.
Okay, thank you, and thank you again for spending the morning with us. I have a number of questions wanting to drill into the specific concerns that you enumerated for us. But before we do that, I do want to take questions from other members of the subcommittee. And so I don't know if we have anyone in Southern Nevada that would wish to address any of these items. Assemblyman Hambrick, are you down there solo now?
Mr. Just for a few moments, Assemblyman Carlton will be back in a few moments.
Okay. Okay, well then I'll go ahead and proceed with some of the questions that I have. The first one, I wanted to talk about the level 3 NICU status, and I absolutely understand how important that is. But I want to hear more about what, in your mind, the specific aspects of the proposal as you understand it, how that impacts the certification. So what exactly are we talking about that would suddenly be less than fulfilling for the certification?
Yeah, this is Dr. Hendrickson again. The children, the babies have to be set up with follow-up care for whatever services they need in terms of feeding, medical care, speech therapies, and follow-up developmental care. And so right now, that follow-up is automatically scheduled to go. Babies under a certain level of prematurity and with certain medical problems are automatically referred to NEIS. They're handling that responsibility, that criteria that's required for level 3 certification.
Okay, and so as you heard, the division, the new division, the division that'll be absorbing this, explained their model this morning. You feel that still is not sufficient?
I think there's too much potential for kids to get missed, to get lost, to not get followed up if it's just fragmented like that. I mean, right now there's a clear line that goes from the NICU to the NEIS, and those kids get followed up. They get called if they don't appear. I just think there's a lot of advantages to having everybody who's working on this problem in the same place. And the history that NEIS has of following these kids and making sure they get what they need.
Okay, and that closing of the feedback loop back to the physicians, as we heard from Dr.
Right.
Coletti, is also
Right.
the concern with the fragmentation. Okay, okay. Just checking my notes here because I think I've got a few of these that I wanted to have the division weigh in on at a later time, later this morning. Okay, that's what I have. Assemblywoman Carlton, I see that you're back with us. Do you have any questions for our panel of pediatricians?
No, thank you, Mr. Chairman. I thank them for taking the time to spend with us this morning and share their viewpoints. I do appreciate it.
Okay. One final question before you leave.
Oh, but Mr. Chairman, I apologize. I believe Mr. Hambrick has a question.
Okay. Assemblyman Hambrick.
Thank you, Mr. Chairman. Dr. Hendricks, and, earlier in the testimony, there I think I heard some concern about the community providers. I'd like to drill in that just a little bit. What are the major concerns or your heartache about the community providers as to what we see potentially coming down the pipeline of adjusting some of the services? And I understand from the medical side there, but I would like to hear some more detail on your exact complaints or concerns about the community providers.
This is Dr. Hendrickson again. Many of the individuals within the community provider system are excellent and wonderful, and we have been overall, I think, doing okay with the model where there's the public-private partnership, where NEIS is partnering with some of these groups. Although I agree with Dr. Coletti, the communication is not as good for some of them when the kids go out. There have been specific complaints about one of the community providers that are fairly widespread among the pediatricians in town, as not seeing the kids as often as they should be seen, as not providing the services these kids need, as not having the staff that they need to really address the complicated issues these kids are facing. So, There are issues with some of them, and some of them are wonderful. But I think what's more salient, what we're trying to address, is the role they have in the system. When NEIS is kind of the center of the spokes of the wheel, and they're partnering with groups, with private providers, as opposed to scattered, 5 private providers and no centralized place where all this is really managed and administered and handled. Does that make sense? So it's we're objecting to the model, and we have some specific problems with some of the providers, but I don't know if this is the forum to bring that up, but there have been some issues.
Okay, thank you, Mr. Chairman.
Okay, thank you. I guess I also want to hear some comments about your communication with NEIS regarding this change in the model, specifically with the 2 divisions. There was reference earlier to a bringing together of the community earlier this year to discuss these changes, et cetera. Were you a part of that? Was there outreach to you?
I did not talk to a single physician who had any idea this was happening before we called them.
Okay. All right. Thank you again for spending the morning with us. What I would like to do is to take and please feel free to sit down and stay with us if you can, but I understand that you might have to get back to Reno. I would like to shift for the next few minutes down to Southern Nevada, and I'd like to deputize Assemblywoman Carlton to receive input from the folks that we have signed in down there for the next little bit. Assemblywoman, are you ready to take that on?
I'll back you up, Mr. Chairman. I'm here for you.
Thank you so
I
much.
believe we have a Mr. Burns and a Mr. James and Miss, I believe, Cannon, all marked in as wanting to testify. If you would all like to come forward. And just because I called those names does not mean we are limiting anyone else's opportunity to testify. If you would like to testify, just take a seat after one of these 3 folks is done, and be sure to introduce yourself, and then I'll have you sign in afterwards. We don't want you to think that you can't come up. So if you would please just remember to introduce yourself every time that you speak, so that our able staff up north, when we do the minutes, has everyone's statements correct. So please, we'll start with ladies first.
Good morning. Thank you, Assemblywoman Carlton. My name is Sally. Am I too quiet? Okay, I'll speak up. My name is Sally Cannon. I'm Director of Early Intervention at Foundation for Positively Kids in Las Vegas. I'm going to keep it short because I know your time's very valuable. I've just been jotting some things down. I didn't really come with a script. I want to kind of speak from the heart, and we'll see how that goes. My babies are my number 1 priority. And I get very emotional when I speak about my children. We've been doing this for 3 years. I've never had a wait list. We have an audit every single year, and this year the audit covered 7 areas of compliance and things. We got 5 areas we were 100%, and 2 areas we were 99%. I know that Miss Mary Liberati spoke about compliance not always being the most important thing, and outcomes are important. They're both important, and I just strive for the best for my children. And maybe this is going to be a little bit too honest, but I feel like we're, as community providers, and they may not agree, but I feel like I'm on a bus, and I'm not driving that bus. That somebody else is driving it, and we're just along for the ride. And I know there's different opinions on how people feel. I want the best for my children. Do I feel that going to this new model is the best for my children? Maybe not. I'm an A-type personality. I like to be involved in all of my families and all of their cases, and maybe it's just that A-type personality that I don't feel comfortable giving up the reins and sharing that role with NEIS. Maybe other people feel different, but I'm just being completely honest with you. I wrote down that the state costs more money. I looked at that page 147 of this book, and their developmental specialists get paid a lot of money. And that's their business, and I guess what we pay our staff is our business. It is in that rate study. We pay a lot less, so, if you want to save some money, maybe look there. They always talked about how much it costs for therapists. I think all of the providers got together, and our median rate was $92 a session for a therapist. I do have concerns that when we go to this new model, let's just say in Southern Nevada, to keep numbers round, there's 1,000 children out there. So the new model basically says that my 237 children for service coordination would go to the state, and they would do service coordination, and then their 1,000 children for therapy and developmental services would come to the providers. So there's 1,000 children. In the South, there's 5 providers. In essence, that's 200 more children in my program. Assemblywoman Carlton, you mentioned that I can say no at any time. I don't know if I'm comfortable taking my program from 237 children to 437 children. I strive to have no wait list. I don't want us to be on a conveyor belt of children. I like being involved. I know, I won't say every single child, but I probably know most of my children, what services they get. I'm very, very involved. So that does worry me, and then it worries me that are we going to bring on lots more providers, and are they going to be qualified, and there's a shortage of therapists, and where are we going to get them, and I guess I could go on, but I'm going to end there. So thank you for your time.
Thank you very much for being here today and listening. Mr. Chairman, if it's okay, I'd like to just ask a brief question. And I understand your concerns. I think this has to be a partnership from the state and the community providers. And different providers have different strengths.
Definitely.
And I am afraid that we are going to ask from one what another is better at doing.
Mm-hmm.
And thank you for bringing up the wait list portion of this. I do appreciate it. So currently now, you can, when you hit your contracted mark, you know who you can take care of, then we don't put more children on you than you can actually service. You do have the option now of saying, I'm at capacity, call me in a couple of months, or let's talk later. That's currently how the system works for you.
For the record, Sally Cannon, Positively Kids. Yes, Assemblywoman Carlton, that is correct. I think in our contract it states that every quarter we're supposed to report to the state how many children we would like. Do we want more? Are we happy where we are? I think the consensus is if we don't tell them, then we're okay to keep having more children. But there, in the 3 years, I think there's been twice that I've said, I want to go on hold for a week. I'm a little overwhelmed. I've got a lot of my staff going on vacation or whatever. I'm happy. And don't give me any children for 1 week. And then we've resumed back up. But yes.
So the state, in essence, does act as your safety valve.
Yes,
in a
they
way.
do.
So, and with some of the discussed changes, that valve your concerns are that valve may no longer work, and you may end up with children that you would struggle to serve. You would still get there, but you would have to struggle to serve them.
Yes.
Would that be a fair statement?
That is a very fair statement. And I guess my big concern is in your finance committee that they're thinking about reducing our rate, because we're not going to do part of the model, which is service coordination. Okay, so you're taking away that part, you're going to give me more children, and there's a shortage of therapists. And when it's supply and demand. When our rate was cut the last time, we went from average of paying, a lot of my therapists get $100 an hour. And supply and demand dictated when we had our rate cut, we're not going to work for you. Well, if there's only 3 OTs in the valley, I can't just say, oh, okay, well, I'm not going to take any children that need occupational therapy. So I have to give them more money to keep them. So my big concern is that if the rate is cut, and that has to come from somewhere, somebody's salary has to get cut. So if that's going to go to the therapist or my staff or whomever it is, my big concern is they're going to say, you've already cut our rate last November, you're going to cut it again, supply and demand, I'm not going to work for you.
Okay, thank you very much.
You're welcome.
Mr. Chairman, anything from up north?
I think you are still being deputized, Assemblywoman. Could I ask a question, please?
Sure, Senator Kickheffer, please do.
Thank you. Ma'am, there are, it's been suggested that that the community providers are able to, quote unquote, cherry pick the cases that they get. When NEIS calls you and asks if you would, if you have capacity for another child, are you given any indication at that point in terms of the scope of that child's needs and whether the IFSP is going to be robust or slim?
For the record, Sally Cannon, positive kids. Senator Kickheffer, no. I get an email that says you have a new child. I go into the track system, and in there it will say referral reason, speech, gross motor delay. That's the only thing. Or maybe G-tube. If it's an auto eligibility child, it could say G-tube. That's the only thing. If a mom gave more information, my child can't sit still, has behavioral problems, that may be on there also. But no, then when we call that family and we set up the initial eligibility meeting, at that point, it could look like a speech-only child, and I know that my staff have come back and said, wow, we thought it was speech-only, and now that child needs feeding, OT, PT, speech, behavior, vision, and every single service that we offer. I also kind of want to put it out there. I have been a developmental specialist before. Maybe this is way too much information. As a developmental specialist, I had no idea about money. And maybe this is just being naive, but I didn't even know that the state gave us money. I had no idea. And now I'm in a director position. My staff have no idea. I've never said to them, we get $565 and that's if I've got $100 a staff member, you only can give X number of services. They do not know. My thing to my staff is you give that child what they need. If it ends up costing me $2,000 a month, I'll figure it out. That's my problem. It's not their problem, and it's not that family's problem, and it's not that child's problem.
Thank you, sir.
Thank you very much. Anything else, Mr. Kickheffer? You're good?
I'm good, thank you.
All right, thank you. We'll go ahead and proceed then. Please introduce yourself for the record.
For the record, Assemblywoman Carlton, my name is Robert Burns, and I'm with Therapy Management Group. And thank you for the opportunity to address this body today. And for the record, I'd just like to say, reiterate some of the points that Sally made about Positively Kids. Here at Therapy Management Group, we too have not had a waiting list. Our capacity and ability to serve might be slightly different than hers in that we are, ready to take on more children should the state decide that that's what they want to do. But we serve at the state's pleasure, all of us do, and are happy and proud to have done so for the last 3 years. A little bit of background on Therapy Management Group specifically. Both Mark and myself are therapists. Mark is a speech-language pathologist, and I'm an occupational therapist, and the other principal owner, Patrick Santoro, is also an occupational therapist. And we, the three of us, have also worked for almost 5 years, each one of us individually, with the state through Nevada Early Intervention Services as contracted therapists before we started this venture in providing services as a community provider. So we feel that our frame of reference is unique in that we see this situation as an opportunity, a unique opportunity to meet the state's need to service these children. And we see it not only from a community provider's point of view, but we also see it and recognize it from NEIS's or the state's point of view, and think that there is an opportunity that continues to exist for us in concert and partnership to eradicate this wait list, meet the state's fiduciary responsibility, and move this program and these services forward in a way that doesn't compromise care.
Okay, thank you. And I would assume then that your group sees children from other referral sources that may have, it's just not from the state, it's...
The bulk of what we do is early intervention. We have had and maintain contracts with the school district through some of the charter schools, but our primary focus is early intervention.
Okay, good. Thank you. It's always nice to understand the universe that you're discussing. Thank you so much. Mr. James, did you want to go ahead?
My name is Mark James with Therapy Management Group, for the record. We, again, just want to say how grateful we are to be participating in this process. Each of us have a desire to serve these kids in a very effective way, but also understanding the fiduciary responsibility that we also have. We feel that there is a way to make this work, both for the children on the wait list as well for all those who are involved. And listening to the physicians up in Reno, as a speech pathologist and a feeding specialist, one who works with those children who have G-tubes, and one who understands the very important role that is needed in that NICU follow-up. We've play that role and seek out that role here in the South as we work with some of the hospitals and trying to educate them and about early intervention and the follow-up that we can help provide them. Also, we have just started to provide services up in the Reno area as well as here in Las Vegas, and have a relationship with Dr. Kinman and look forward to expanding that relationship with the other pediatricians up in Reno and other physicians up there, because we agree that continuity of care is very important. Thank you.
Thank you. Thank you very much. Mr. Hambrick, did you have a question?
Thank you. I'll go to Ms. Cannon first, but again, the question, anyone can answer it. You stated a little while ago that occasionally you have a difficult time getting certain therapists. And then when we had Ms. Lavarati talking, where she has the Category 12 employees, then are you in direct competition for those bodies to turn around and come service you, or are you not? You know, the technicians or the therapists, she said she hires Category 12. Could they also at some point be working for any one of you or other service providers and go back and forth? So I'm just trying to get some idea of the universe of therapists and what the competition is.
This is Robert Burns, for the record, Therapy Management Group, and absolutely, the pool of therapists that the state contracts with is also a pool that's available to any provider statewide. If there's a provider that provides services to the state and they also wish to provide those services to any other provider, whether it's in the EI system or whether it's in the school district or whether it's in private practice, they're free to avail themselves of that opportunity, and it's our understanding that many of them do. And there are therapists, for example, who work for the state or are contracted with the state that also work for the community providers. There are also therapists that work for multiple community providers. Because of the nature of that contract and that relationship, it's essentially up to each individual contracted therapist who they want to work for, how many hours they want to work, and what rate they want to negotiate with those providers or NEIS.
So then, as a quick follow-up, then individual therapists, regardless of the specialty of that therapist, could work for one of your groups, work for the state, and work for their school district all at the same time?
Absolutely.
Okay. Thank you. Thank you.
Okay. Thank you. Earlier it was stated, I'm trying to go back, we've had so many conversations, that there were some current concerns with some of the private providers providing certain information to the state. and I'm not sure if it was in the audit capacity or billing, and I'm trying, and you were here listening to the conversation, and it just struck me that, you know, we audit state agencies, it's federal and state dollars. Ultimately, you know, when the rubber hits the road, we're held responsible within a contract with someone to have a private entity say that they're uncomfortable with us looking at certain things. And I just don't understand where that might come from. And since you're a private entity, could you give me any insight on where that might be coming from, if there's something we need to address? Because you have to remember, if somebody asks me about, you know, providing services for children with a certain group, and there's information I can't get, that puts us in a very awkward position. So if you could shed a little light on that.
Again, this is Robert Burns with Therapy Management Group, for the record. And Assemblywoman Carlton, absolutely, our provider agreement, the way that we read it, is structured such that any reasonable request made to us from the state is one that we must honor. Whether it's manpower, human capital, financial resources, our ability to adequately and sufficiently and with great competency and care meet our charge as it's identified in that agreement it's a mandate that we take very seriously, and to our knowledge we've complied with every single request. And you know, I can't speak for obviously every community provider, but from Therapy Management Group, we have absolutely been in complete compliance with any request that we've received from the state regarding any records. As a matter of fact, you know, one of the things that we've done is we've moved to an electronic system and essentially given Part C the keys to our car. And so anytime they want to come in and check on compliance issues or IFSPs or any status with regard to us meeting our obligations on the IFSPs, they can do so at any time.
So you don't think that's an undue burden that we would be asking, and that, am I right that if someone would refuse to provide certain information that our antenna should go up and we should look a little closer, because it seems to not be a problem with most of the providers?
Assemblywoman Carlton, this is again
And
Robert
I'm just
Burns.
asking for your opinion. I'm not going to put you on the block here, but your opinion would matter. You do business with us now.
Certainly.
So.
And it is, from our vantage point, again, it's a pleasure to service these children through this provider agreement, and it's our view and our goal and our position that anything that we can do in terms of providing information that will help the state meet its obligation, we're happy to do so and continue to do so. I don't see it, or we don't see it rather, as an undue burden. We see it as, in some respects, as a necessity for the state to make sure that, you know, we're doing the job that they've entered into this provider agreement with us to do. So again, from our vantage point, we don't see that as an undue burden and are happy to comply.
Okay, thank you. And I think the chairman's back up north, but I'll just ask one more quick question. You were here in the room when we did have the discussion about the payment schedule and the time frames and some of the concerns that we had about that. Is there anything that you would like to put on the record in regards to that being one of the individuals that this discussion applies to?
Assemblywoman Carlton, this is again Robert Burns, for the record. One of the caveats or pieces that may have been missing from that conversation was the fact that as community providers, we don't get to decide when the child comes to us. We don't get to say we'd like to receive all the children the first of the month, or the 15th of the month, or the last day of the month. As I understand it, when the parent calls the single point of entry and initiates a call to get services, the clock starts ticking in terms of the 30-day timeline, the 45-day timeline, and that child's clock starts ticking or is initiated by the parent. It's not something that we have control over. So if the state sends us a referral on the first day of the month, or the 15th day of the month, or the last day of the month, we're going to immediately start the process of exceeding that 30 of beating that 30-day or 45-day timeline. We don't wait to start services. We don't wait. As soon as the referral comes off the fax, we get busy serving that child. And I think that Mary Wary did make the point that the rate isn't something that can be so easily teased out in terms of an hourly rate, and even like Ms. Cannon said with regard to her staff, the 565 encompasses, I think, what our charge is in its totality, because there are children that we provide a quality service to in determining eligibility, that while they aren't eligible, our responsibility and obligation to them has to be met. And I think that the rate encompasses that piece of it as well.
But you do understand the concerns that we have when
Absolutely.
we're looking at things. The mantra these days is transparency and accountability. So you know that we always have to be looking at those issues. So I appreciate you sharing your time with us on that. Mr. James, did you have something you'd like to add?
Yes, this is Mark James with Therapy Management Group, for the record, Assemblyman Carlton. Just as an example of what that may look like on the ground, I may see a child who needs those NICU follow-up services, and they're found eligible for the program. I may see that child every day for a period of time until I'm confident that that family and that child are doing okay. And those are very intensive services that are provided, and those may fluctuate based on the needs of that family and that child. So that rate, also structuring the rate in a larger group also cuts down time and effort that the state staff have to try and figure out every small service. If every small service were to be billed individually, that would increase costs for the state oversight to figure that out. But again, we are mandated and also have the desire to provide every service for every child. We were in a visit yesterday where we had a whole team working with a family in that family's home. Now, if you look at the cost of that visit, that it costs for all of those different therapists, developmental specialists to be in that home for that child, for that single child, you've almost taken that whole 565 and it's gone for that child in that one visit. So there's a balance, for those children who may not need that level of service.
Okay, thank you. Thank you very much. And I just wanted to make sure you understood the reason for our discussion. Mr. Chairman, do I see you in your chair up north?
Yes, you do, but Assemblywoman, I think this is for the sake of moving through this and collecting as much information as possible in the time that we have. I think it's working rather well for you to facilitate the public comment down in Southern Nevada. With that said, we do have one question up north here from Senator Kiefer for the panelists.
Thank you very much, Mr. Chairman. I wanted to follow up on Mr. Hambrick's questions, and it had to do with individual contract providers who could work for both you or the state through Category 12. Is there a differential in the rates that are paid, or is there a consistency?
This is Sally Cannon for the record, positively case.
Close to the mic.
Oh,
Yeah,
I'm sorry.
It's hard to hear. Thank you.
Okay, this is Sally Cannon, positively case for the record. Senator Kiefer, I can't speak for the other programs, but when a therapist comes to my program to interview and they talk about the rate, all of my therapists negotiate their own rate. So whether they've worked for NEIS and maybe they were getting $50 an hour and they say, okay, I want to get $60 an hour, or whether they came from the community. And like, I actually had somebody who came in last Friday, a PT, and she said, I don't expect you to pay me what they pay in a clinic because that's $140 an hour. my eyes almost popped out of my head, and I'm thinking, no, I cannot afford $140 an hour. But they all do negotiate their own rate. And I think that goes from program to program to program as well.
This is Robert Burns with Therapy Management Group. And Senator Keycapper, that is our experience as well, that each individual contracted therapist would approach us or be approached by us, and then the negotiations for their per visit rate or per hour rate would be settled at that time. But there's no fixed rate even across disciplines within our program. So different contractors, depending on their level of experience and expertise, command or negotiate different rates.
Yeah, and I'm not going to ask you to disclose anything that may be proprietary, but the is the rate? Yeah, I don't know. I kind of want to push the envelope a little bit. Does the rate that the state pays on contract basis, is that set, or is that negotiated on a case by case basis? And maybe Mary's coming to the table to answer that question because she's the expert.
Well, that's a scary thing. For the record, Mary Wary, Deputy of Clinical Services for the Health Division. In the Phase 4 rate study, I believe is in your book, and I'm sorry I didn't bring it up here with me, but there's a page or two that actually shows what the average rate is for the private sector for their therapies. I think it was like $99.16 or something like that. And again, Jennifer Olette has their cost information, has the track data, and she is available to you for us to make sure that she can be the one to share with you her comparison of the state's cost to the private sector's cost, because she's looked at the entire bucket. When we have an Avision contractor, our contract with Avision, as through the Department of Purchasing, has a fixed rate for the different type of contractors. So it's $50.11, I think, for most of them. We do have a few variations for the frontier area, for example. They may get $57, but it's specific to each type of therapy. However, if we don't have enough of the Avision, then we do have provider agreements where we have to go out into the community and find individual therapists, and that's where the rate has a wide variation, just as they're describing they have the same experience in the private sector.
So is that one of the areas where we create this gap in availability of these services? I mean, if we've got a limited provider pool, is it that we don't have enough fiscal resources to get the kids into services with these individually negotiated rates because we don't have a robust enough provider network? You understand my question? I'm sorry.
I
thought
think
there was
I do. I mean,
another clause in there, but I forgot it.
You know, it's been a long time since I've taken economics, but it truly is a supply and demand issue when it comes to the therapy cost, and almost the same for the intensive behavioral services. There's a limited supply and there's a huge demand. And we compete not just for serving these children 0 to 3 with developmental delays, but we compete with the entire consumer demand for therapy services for all ages of children. Sometimes we compete with the school district because they are using the same type of therapist for the kids in the early childhood program 3 to 5 and then the kids 5 to 22. So there really is a supply and demand issue. It really does present an economic challenge, and that's why it's been, I guess, desired from our perspective to kind of make that the private sector's problem. By giving them a fixed rate, they've got to negotiate those. And some of it's a volume issue. If you can guarantee, it's what the managed care plans do.
It's a capitated rate.
If you can guarantee a physician that they're going to get all the referrals into the managed care plan, then their practice is going to be very busy, and so maybe they'll go for a lesser rate. And so that's something that the private sector can also do that the public sector isn't so nimble with doing. I was trying to find the exact page that had those provider rates on it, and it's not jumping out.
I'll flip through and find it, Mary. Thank you. I think you've answered my questions.
Thanks.
And Senator Keycapper, we've been talking about workforce and licensure for years, and that always seems to be one of the stumbling blocks whenever we have an issue about access to care in any world in this state. So it's always about the workforce and getting the appropriate amount of workforce in. I believe Mr. Hambrick had a short follow-up to that line of questioning.
Yeah, Senator Keffer are sort of bouncing off each other on this one. Mary, if you're still at the table up there, I guess the question would go to you. But Mr. James, I'm going to use you as an example, so forgive me. But since I now know you have two specialties, speech and feeding, if I'm correct. All right. Mary, would it be possible then, in the system, if you have a Category 12 employee doing a particular service for a child, could that therapist technically charge twice for the same child because of the two different specialties? If a child needs speech therapy in a feeding tube, but one comes in as a community partner, and then you also might have a Category 12 or some, is there a possibility that a given therapist could technically charge twice? Granted, there are two different services going on here, but could a child then, get the services and then the therapist could be able to legally double bill?
Thank you. For the record, Mr. Hamrick, no, I think I understand your question. Each of the services that has to be provided is a IFSP service. So a child may have a speech therapy service on their IFSP with a frequency of 2 times per month. And they may have a feeding service on their IFSP that may be once a week. So there would be a total of 6 services, and it may be the same clinician that's providing all 6 of those. Chances are it may not be, because feeding is a very specific specialty that may be done by a person other than a speech therapist. The way we allocate our dollars is based on the track data, the software program where all of the IFSP services are entered into the system. So if somebody was billing for something that was not on the IFSP, then we should not be paying for that service.
Okay. Good, Mr. Hambrick?
I see Mr. James is just ready to hit that button.
And Mr. James, did you have something that you want to add?
This is Mark James with Therapy Management Group, for the record. Just one piece of information as you look at the data is there are different methods of paying therapists. Some are paid by the hour and others are paid by the visit. And so the way that a particular business model or whatnot changes some of those numbers a little bit. But sometimes there's increased flexibility with paying one way versus paying another way. And that also may have an impact on the therapist's productivity and their desire to actually see more kids with the amount of dollars available.
Okay, thank you. Mr. Chairman, I believe that wraps it up with the 3 people I have at the table who had marked on the sign-in sheet that they did want to testify. Is there anyone else in the room that wanted to have public comment on the record right now? Seeing none, I believe we're done in Southern Nevada, Mr. Chairman.
Okay, thank you very much. Let's see, I believe, Mary, I think what would be appropriate would be, at this point, we're going to keep going, unless it is, and I'll look for a head nod, unless it is absolutely pertinent to a specific point that was just made. I do anticipate having some agency response to the general range of public input later.
Thank you. Mary Worry, for the record, and I'm sorry, I'll just keep this very brief. On page 83, the slide I was looking for, I remember we took it out now because it was confounding. So what we did is we put pie charts on instead.
And the rest of this?
It makes perfect sense to me.
Wow. I want to hear more about that threshold.
I have a master's in psych mental health nursing. Can you tell? I'm psycho. Anyway. On page 83, what we tried to depict, because the slide that showed the cost of services was somewhat confusing. So what we showed instead is that this slide captures the percentage of services received based on track data versus the cost of the services. So you can see speech therapy accounts for 8% of services received, but it represents 22% of the cost of the
Because the
IFSP
coordination
services.
is that much more.
The cost of the therapist. So service coordination accounts for
got it.
54% of all services provided, but it only constitutes 32% of the total cost of the services. So does that, this is why we tried to clean up this slide
Sure,
to make
yep.
it more clear.
Okay.
Thank you.
Not as confounding. Great. Far from it for the legislature to ever be confounded. Okay, I want to let's move through now. Now that we're back up here in Northern Nevada, I'd like to hear from Mr. Brian Patchett on the perspective from the Easter Seals. Good morning. Got a few more minutes of good morning. Very good.
Okay, here, I got the right button. All right. Yeah, good morning, Mr. Chairman, members of the committee. My name is Brian Patchett, and I'm with Easter Seals, Nevada. And appreciate all the information that's been provided this morning. I think the state's done a great job of providing a lot of good information. I appreciate the information provided by other professionals who've been at the table, other service providers, and so forth. And your patience as members of the committee to really get at what this is, because I think that's really where we're all at. We're trying to get to the best service model that's possible so that we can serve the most children with the best services. Let me just give you a little bit of a background. I've been with Easter Seals now a total of about 15 years with 3 different Easter Seals organizations. Before coming here, I was with Easter Seals Arizona. I've been here for about 8 years now. And really, I think Assemblywoman Carlton had mentioned going back to 2007. I remember that, and I remember the discussions that have taken place across a lot of these years, looking at how do we, meet waiting lists and those kinds of things. And I got into this field of nonprofit world and disability world. It was really an interesting situation for me because, having become disabled, become legally blind at age 7, there was a choice I had to make. Did I want to try to do something to help people with disabilities, or did I want to be kind of away from the disability field? I made a choice in graduate school when I studied rehabilitation counseling and public administration to do that. And so I really have tried to make it my life's work to help people with disabilities, to help people, children, adults, whoever it might be. And at Easter Seals, we serve across the age range. We've impacted probably the lives of about 7,000 people last year across the state of Nevada, whether that be early intervention, whether that be an adult day service we provide, child care, assistive technology, just a range of services. And we work with a lot of different service sectors in the state. We work with from federal services with veterans to the DS services to early intervention and others. And so as I've heard all this, it's been interesting to see the discussion. Also, in my experience, Easter Seals provides early intervention services across the country to about 90,000 kids. And each Easter Seals organization is its own organization, as it were. Easter Seals Nevada there's been an Easter Seals in Nevada since 1950. Easter Seals has been around since 1919 as a nonprofit. We're a nonprofit 501c3. So as I talk to my colleagues around the country and what Mary Ware had said about the kinds of service models that exist out there, it's really pretty true. Generally, most other states have some type of a system where they are contracting with community providers and providing oversight as well. I came here from Arizona 8 years ago, and that was the way that system was working at the time. And it seemed pretty effective. And I think that the system that we're in right now there's been a transition really going on for the last 4 or 5 years. We've been meeting, I think, more needs. I certainly think that NEIS has done a fantastic job of delivering services. I think what we're looking for, as far as from my perspective as a community provider, we're just looking for the best way to serve the most kids and make sure that those services are provided at a high quality level. The other thing that is there's certainly, as a provider, we've grown fairly quickly over the last 4 years. We're currently serving somewhere over 360 children throughout Nevada. We feel like we still have the capacity to expand that, and so we're open to what the state's saying. And I think that the community providers can continue to meet the needs, but as some of my colleagues were saying, it's really going to depend on what that ends up looking like. I think that the rates that we've talked about have made sense. As others have said, those rates have changed over the last 4 years. And I think we're in a place where we're able to provide those services still. I hope that we're able to provide those services statewide. I will say this, Easter Seals has been able to provide services in outlying areas outside of Reno and Carson City, as far away as 2 hours away and so forth. We've been able to do some of that, and we're interested in looking at how we can provide services in the rural, in the frontier communities. And I know there's some question about what that really means given distances and so forth. So again, we're excited to be part of this. Hope that we come to an agreement that will really benefit the children, because the ages of birth to 5 are the most critical time for a child's development, as we all know. And one of the things that we've been focusing on in the state and also nationally is making sure that parents understand exactly what the doctors were saying earlier, that these services need to be delivered, they need to be coordinated, and they need to happen at as early of an age as possible. We get the opportunity at Easter Seals to serve people, as I said, across the age spectrum. I know what it looks like when a child did not get early intervention. Unfortunately, after the age of 5, you can't have the kinds of great impacts and changes in a child or a person's life that you can during those times. And so when we see adults with disabilities who did not have early intervention, there's not a lot that we can do to help them long term. And so I think that this is why this is so critical, and I'm happy that we're having this conversation. Any questions that any of you might have, I'm certainly happy to entertain.
Okay, thank you. Do we have any questions from up north? Seeing none up north, how about from our folks down south?
Thank you, Mr. Chairman. I'll ask Mr. Patchett the same question that I asked the previous public comment speakers. The statement that we had heard earlier about some information not being available and the accountability and transparency issue. I'm sure, Mr. Patchett, you heard that discussion earlier. Can you expound upon that, or do you have any concerns with that? It just bothers me when I hear that folks want to contract with us, but yet they don't want to share all the information that we may need to make good decisions. So if you could address that, please.
Assemblywoman Carlton, I appreciate that question, and I think I hold, at least sounds like I would hold the same concerns that you would. I think that once you make the decision to provide services, you then have a responsibility to the people you're delivering those services to, and a responsibility to any entity that might be providing oversight for that. And so I think about our situation as Easter Seals and just the years of service that we do. Across every single service that we provide for the state, whether it be a community training center service or an adult day program or supported living or early intervention, there are a series of audits that take place every single year. And we open our files, open our doors, whatever information that people want. And the same thing's certainly been true of early intervention. We've had Part C comes out and does an evaluation annually. And that information, I think I sent that to all of you on the committee. There's a website that shows what those audits were, what those self-evaluations and so forth, those things that have been done. Along with that, as a nonprofit organization, we have, well, first off, as a standard, Easter Seals does a financial audit every year. If we receive federal dollars at a certain level, then we have a circular, basically a federal audit that takes place as well. And I always like to say, if there's a piece of lint on the ground, they will look at it when they do those audits. And then on top of all of that, we now have, in the last 3 years, we've had something called the 990, which is basically like a Sarbanes-Oxley type of a thing for nonprofits, where you essentially put all this information into a document, and then that's right out on our website that shows who we are, what we do, and those kinds of things. And so, again, I guess my answer to you, Assemblywoman Carlton, is yes, I believe in transparency, and that all the providers should submit the requested information, whatever it might be.
Okay, and if as this change is further discussed, I would hope that the entities that would want to partner with the state in this would take on and not try to absolve themselves of the same penalties that would go along without compliance. I know the state can be penalized if we're not compliant. If we would find out that we were contracting with someone and they were not compliant, I would hate to have them hide behind their nonprofit status to say that they're not responsible. So
Yeah. And I think I appreciated what you had said earlier.
because that has happened in other parts of the country, and I would not want to see them lawyer up, as we say, and hide that way, because nonprofits do have certain protections that other folks do not have. And I think we would need to pierce that veil to make sure that children were taken care of.
Well, and I agree, Assemblywoman Carlton. I think with the 990, I'm not sure how much of a veil is left. If they're providing information on that, there's a lot of good information there. And I know that that's part of the reason the 990 process exists, because there were such a large number of nonprofits, many of which weren't really doing the kinds of services like an Easter Seals or a Positively Kids would be doing. And so, but I can promise you that, at least from an Easter Seals perspective, we will be completely transparent throughout the process.
Okay. Thank you very much. Thank you, Mr. Chairman.
Okay, thank you. I had one question, Mr. Patchett, about some of the comments that we heard earlier from the pediatric community. This notion that there would be this breakdown in the feedback loop communications that happens following delivery of services back to the pediatricians. I was wondering if you could comment on that. What's been the practice at Easter Seals? Is it a problem? Are there steps that can be taken to address that?
Thank you for that question, Mr. Chairman. It's a little bit different in the North and the South, the way that this works. I think that's probably the first thing I should address. But having said that, in looking at the changes that are being proposed, and maybe it's better to ask that question of the state, I don't think that the change would impact that, at least from what I can see. NEIS there would still be a state entity there that would be there with service coordination to make sure that loop continues. And so I would assume that would not be changed or would not be impacted. I think that there's also some maybe there's some clarification too. Maybe this gets back to different kinds of services. Early intervention is an education-based service that comes from the Department of Education, and that's, we talked about that service. And then there's also the other services that have been meshed with that as part of what has been happening at NEIS that may not necessarily be Part C services. And so I think maybe that's some place to look and see how that's really combined in the North, maybe a little bit differently than in the South. But that's probably about the most information I can come up with, unless there's something I'm missing from your question.
Okay, no, that's good. Any further questions? Okay, thank you so much for your time. Still going through the list, I believe I have, and I hope you don't take offense at me calling up multiple people at this point. I have Julie Ortiz and Diane Ross. Would like to come up and provide us with comment. Good afternoon.
Good afternoon. Thank you for having me. I am Julie Ortiz. I am initially a speech pathologist and then now a business owner of Advanced Pediatric Therapies. I have been in business providing specialized pediatric therapy to children mainly in Sparks, only in northern Nevada, for the past 10 years. I had a relationship with NEIS prior to becoming a community provider, as when they couldn't fulfill speech language services, they would ask us to fulfill that for them. July 2010, we became a community provider. And I have to say that it's been, and I've told Mary and other people on the state side, it's been one of the most rewarding and most challenging positions for us.
It's kind of like being a legislator.
Right? Speech path, politician wasn't in my domain, but it's been amazing. And I do want to give credit to the northern staff of Nevada Early Intervention. They have been amazing in giving guidance as we take on this charge to provide these services. And it was quite a pleasure to know that we were stepping on in a community that's very close-knit to help support the children that were on that wait list. And that's still my priority as a pediatric therapist and a business owner who's doing the community partnership, is that it does remain a partnership and we collaborate to meet these children in our state in a timely manner so children are not waiting on the wait list. In regards to the current plans or models that are still going back and forth, I do echo Ms. Cannon down in the south, that I do feel that the current model that we're running under is the best and most comprehensive for the families, that we will all be able to stay the most coordinated. And by that, I don't mean stop growing the private so much, but also that we as the private do retain our service coordination. I think it's vital that we are able to make the system as fluid as possible, and we don't have to stop our visits to contact the state case manager, service coordinator, to make the changes that need to be added or deleted at that moment to the IFSP. I also can echo Sally in saying that I'm also a speech path and very type A, and part of it might just be that transition and change. So what change does need to occur, I think it needs to be very thoughtful and presented well to the families and the providers, and that we do pick the model that will best serve the families, not the design of the politics and the budgets there, but will really serve the families. And I do understand that we do have to get the most bang for our buck, and that we do need to get kids off that list with the best that we can. So it is of additional concern to me that children are waiting on the list. For community providers, there aren't any children waiting on the list in the north, and there's only, I think, around 9 or 11 statewide, so I don't think that that's a big concern for community providers. I think it's Assemblywoman Carlton who keeps speaking in the South as regards to if we can say if or when we want children. I know the demographics from the South to the North is quite different in our populations. I know in the North, I'm constantly asking for numbers. I've never once turned away and said, no, we can't take more. There's definitely room for growth. In fact, in the North, we've gone through over the past 2 years a roller coaster of our capacity being increased, decreased, increased, decreased. So from a business perspective, that makes some fluctuation for our staffing needs. But we started off this new fiscal year already overserving what we were given as our capacity. So we're sitting and waiting for children to age out and receiving very few referrals unless they are a specific request of a parent or physician to come to us directly. And the wait list is growing. So we are waiting with open arms, and staff who are stagnant in their time right now, waiting to provide those services that children are waiting for. So I do hope for the continued growth with the public-private partnership. I feel that it's gone well in our region, and it's been an absolute pleasure for us.
Okay, thank you. And I think, the point there is that all of us on this panel want to make sure that this is resolved in the way that is best for the kids and best for the families. And of course, our challenge as legislators is that when we say that, we're talking about the whole state. And so we have to look at this, and this is sort of the necessity of this conversation, is that we got to get people synced up as to what exactly we're doing, and we have an obligation as the legislature to look out for the interests of the people. So that's what we're here. So thank you for your comments and your involvement with this issue, because we do value the input.
Thank you.
Great. Good morning, or good afternoon. Just caught myself.
Good afternoon. I have to be out of here by 1:30 because I have a speech pathology interview. So it's
okay. There's no way I was going to give you that much time, but okay.
Thank you. Thank you. I will be very brief because I don't want to be redundant, and I certainly echo the things that Julie has said. A couple of things. One thing that really concerns me, and I'm sorry that the pediatricians are not here, because the Continuum has been strong proponents of medical homes for many, many years, and the idea of the communication between all of us together is where the quality of the service delivery comes with our children. So I'm Diane Ross. I'm the CEO of the Continuum, which is an intergenerational rehabilitation health and wellness program in Reno. We've been around for 20 years. Our program provides physical, occupational, and speech therapy. We have an inclusive infant, toddler, and child care program. We have an adult day program, lots of intergenerational stuff going around. And for the last 3 years, we've done early intervention services. And that was at the request of the state, because our job was to fulfill, to help with a wait list, which we did. I think we all were able to achieve that. All of our employees are salaried, and we don't do any contracting. And I want to say, too, that I have worked with Aging and Disability Services for about 20 years, mostly in the geriatric population and the disabled population. And I will tell you, I am really pleased that they may be considered taking over the EI program. I felt bad. I'm sorry the doctors aren't here because I think they've done a wonderful job in caring for people with disabilities. And we really need to have that continuity of care because many of our little ones are going to have disabilities all their lives. So the continuity of care needs to be there and that we're all in one place. I also believe what both Mary said. I frankly think the EI program has a long way to go. I think there's so many things that we could do to make that program better. To jump into something immediately I think would be wrong, and I think that Aging and Disability is willing to say, let's take a look, let's go slow, let's look at how we can do this, because one size does not fit all. And if we can look at how to create a program that meets the needs of every different kinds of family and their issues, as well as being cost effective, then I think maybe we could even be #1 in the United States. So thank you for listening to me. I'm happy to answer any questions.
Great, thank you so much, and thank you to both of our panelists for hanging at the table for a second. I did want to see if there was questions from Southern Nevada for either of the two of you. Anyone down south? Anyone up north? Yeah, no, I do think, appreciate the comments, appreciate, again, the input and hearing from the providers as to, how to best move forward with designing an effective program. Diane, you made the comment that rather than having contractors, you have salaried employees. Could you talk a little bit about your business model and why you've made that decision? Because certainly, as we've heard, the capacity can expand and contract pretty regularly.
And we do that. Right now we're kind of contracted, like Julie was saying. Well, we didn't start off as an EI program, and so we kind of absorbed that program. And to be very honest with you, I was a little leery about joining the early intervention program because it was a very different model. But then I got to thinking, well, maybe we have a little hybrid going on here because we are different, and that maybe we can provide services that may be a little unique to the continuum. And the other reason was our PTs, OTs, and speech pathologists all came to me and said, we recognize the importance of working to 0 to 3. We know that if we can get them early, then maybe we can get them out of the program and into the school district and bring in more kiddos and serve more. And so as a result, we don't have just therapists that do EI. Our therapists treat all pediatrics, and many of them treat the geriatric population as well. And that's our model. We're salaried for all of our therapists.
Okay, so if anything, what you could say is because you have a broader range of services and populations that you can absorb those fluctuations perhaps a little bit better. Okay.
Yeah, it's a little easier to do that, but we also have our developmental specialists, which we never had before, and they're kind of hanging out here right now. So that becomes an issue, but then it also becomes creative on our part, too, as a private practice person, is how can we use those in another capacity? Okay. That's a thought.
Great. Okay, if there's no further questions, thank you both for spending the morning and now the afternoon with us. And we look forward to your continued involvement with this issue. At this point, I have exhausted everyone on the sign-in sheet, so would like to open it up for anyone who hasn't signed in, who wishes to get something on the record. And if not seeing anyone else, specifically a call to Director Wilden if he'd like to get anything on the record. Now would be a great time. Good afternoon, Director.
Good afternoon, and thank you for the opportunity to talk. Sat quietly listening most of the morning, and I guess I'll start with, I think I'm on Mars. I've absolutely listened to the discussion this morning, and I think we're in a situation where there's a ton of a lack of information or there's a bunch of misinformation, and I would like to try to correct at least some of those perceptions. And let me start with, I think we're evolving through time here, and I want to give a little bit about history and try to explain where we're trying to end up. Clearly, at the last legislative session, we had a difficult budget closing, and choices were made and most of us were in the room, and choices were made as to how we were going to close the EIS budget. Today, sitting here, 2020 hindsight, errors were made, probably around the clinical versus natural environment, probably around the staffing ratios, those kinds of issues, sort of water under the bridge. But that said, we were left with a process where there's 3 ways we deliver services to children and families. The state employee model, the temporary contractor Category 12 model, and the community partner Category 14 model. What staff and the department are faced with, obviously, is that you have to balance between those models. And Mary Warrior and others have talked about the CAT 12, the temporary contractors model, is going to be projected to be out of balance by $1 million. And so we're taking actions to shore that up. And then where we want to end up, and that's where I really want to talk about. So, I mean, this model or pilot or whatever term we want to use, to me it's really an evolving model. I don't think we have an answer today. I wasn't at least prepared to come in here and say, here's the exact model that we're going to do. It is truly, I believe, a state-community partnership that we're trying to evolve to, and let me talk about that. I feel bad, again, that the physicians are not here. Someone has provided information, I believe, that says we're eliminating NEIS. That's what I heard this morning. We are not eliminating NEIS. NEIS is authorized 169 employees. NEIS is being recommended for the next biennium to have 170 employees. And I'm probably breaching confidentiality here until next Monday, but I just feel like I'm on Mars.
It worked out that we held this at this date after all, huh? All right.
I feel like I'm on Mars. Somehow people feel like we're eliminating NEIS. NEIS will continue. Now let me explain what the proposal is in the department. NEIS is in the Health Division. We're proposing that NEIS go to the Division of Aging and Disability Services. Forget the word aging. We're talking kids in this context. Aging already runs the ATAP program and runs other disability programs. MHDS, Mental Health and Developmental Services, runs the 3 regional centers, developmental services, what's that program called? The FPP, the Family Preservation Program. Those kinds of services, what we've been evaluating is that children and families sort of ping-pong through the various divisions for services. You know, you can be at DS, oh, well, we need you to go to ATAP, oh, well, we need you to go to early interventions, or vice versa. We're really trying to put the disability programs under one central administration. We are not trying to blow up NEIS. We're not trying to create some new animal that is going to lay off lots of employees and make doctors and speech therapists and people not have jobs. That's not at all our intent. We're trying to play with the delivery model and figure out the best delivery model. So that's kind of the organization. State versus community costs. Again, we've been spending a lot of time. Mary has talked, both Marys have talked a lot about phase 4 rate study. We'll probably have a raise 5, a 6, a 7. We're probably not going to be done with rates for quite a while. Again, you do stuff, you change rates. And they may not be called formal phase 4 or something like that. I live in the Medicaid world. We are in rate analysis every day. And so we will probably be in rate analysis as long as we have community providers. We'll be in rate analysis forever. You tweak the system all the time to try to get the desired outcomes that you want. And so I really think the whole rate thing is going to be ongoing, and I don't ultimately know. You have to budget something. We are budgeting something. I can tell you a budget has been submitted, and we have a rate structure proposed in that budget. Whether that'll be the perfect one, it probably won't be. Again, we'll be analyzing some more. A couple other comments. I feel like I'm rambling, but I just heard all kinds of things that I made notes on. Budget stability. Absolutely, the letter of intent, in my opinion, was about budget stability. It was about caseloads. It was about rates. This program has had a long history. I've been the director 11 years. All 11 years, we haven't had caseload or budget stability. And it was about trying to get a group working on caseload projections and budget stability. And again, there's a number of ways to do that. And I think the staff and the community providers and others have come a long ways on that, and I think you'll see a much better product being proposed in the state budget. Staffing issues, let me talk about that for a minute. There's a lot of discussion about, okay, let's not have community providers, state staff should do everything, state staff are wonderful. They are wonderful. I think the community providers are wonderful. But we're in a situation, like it or not, it's difficult to recruit state staff, it is difficult to retain state staff. You can't provide the T's, the occupational speech, those things at the salaries we pay. And then not at the salaries we pay, but you got to bring them in at step one and promise them that they're not going to get a salary increase for some years. It doesn't happen. And so therefore, what happens? Cat 12 has to grow because we have to go buy the services because we can't provide the services. Or you have to go to community providers. And so that's the situation we're in with state staff. But again, 170 state staff, I am not intending to lay off or eliminate a single NEIS employee. And I'll say that again. We are not intending to lay off or eliminate a single NEIS employee. Communications was brought up a lot by physicians, and I really appreciate Diane's comments about communications. I don't see why there can't continue to be good communications. We're already in a trifurcated model where we have state staff, temp contractors, and community providers. And if the communications are good or bad today, we need to improve upon them, but we're not eliminating a communication link. The state, 170 state employees are still going to be there. I think the discussion is really about what do the 170 state employees do versus contracted staff or hours do. And the big issue seems to be over service coordination, and I think that's part of the evolving service model and will be part of the evolving rate structure. Privatization, I think I've already made my comments. We're not trying to privatize NEIS. We're trying to develop community capacity. And that, I thought, has been the direction for the last 2 years. New money that we've got in NEIS over the last couple legislative sessions have been directed toward building community capacity. No different than what we've done in the developmental services budgets, no different than what we've done in the autism or the ATAP budget, no different than we've done in many of our senior services budgets. We've been trying to build community capacity. Comments about removing the state's responsibility have been said several times. We do not intend, and even if I did intend, the state will always be the responsible entity. If we have waiting lists or we're not addressing caseload growth, we can't blame it on community providers. It will be our responsibility, and we will have to deal with it. We are the safety net, and we will continue to be the safety net. Last thing on rates, and then I'll be quiet. I feel like I'm getting too passionate here. As Richard Whitley would say, calm down. Rates, I heard loud and clear. I mean, there's lots of ways to develop rates. There may be some frustration about, the partial month services, those kinds of things. We can certainly look at that. I mean, a lot of our programs run on global rates. It's built into the rate structure. Sometimes you only see a child one day, and sometimes you see them all 30 days. The child you see all 30 days, you're going to lose on a $565 a day contract. The one you see 1 hour, you might make some money on. Again, that is no different in a lot of the rate structures that we work on, but we're certainly willing in the rate process as we evolve to adjust that, tweak that, and find a better solution there. So I would hope, and I'll end with this, I do not want to leave here thinking that we are trying to usurp the legislative's authority over moving from one system to the other. I believe we're trying to work through that framework, and the framework is, as we have that trifurcated, three-pronged delivery system, state employees doing certain things, temps, contractors doing certain things, community providers, we're trying to, in the best way possible, deliver services to those kids and family and move the money in the system to make sure we're serving as many children as we can, and ending up that we'll be coming to the legislature, and I'll say this, same number of state employees and lots more money being requested to go into two categories, 12 and 14, and it isn't exclusively community providers, it's also the contract kinds of people that we need, the specialists that we need, And that request, quite frankly, on Monday will be staggering when you see it publicly.
Wow, you heard it here. Staggered but not confounded.
Maybe perplexing.
Perpetually. Thank you, Mr. Director. Before we open up for questions, I do want to hear from staff real quick on a matter that I had asked be investigated previously.
Thanks, Mr. Chairman. For the record, Laura Freed with the Fiscal Analysis Division. A while ago in the conversation, certain members of the subcommittee had expressed concern about the necessity of a budgetary BDR in order to effectuate the move of EIS from the Health Division over to ADSD. And DHHS staff had said, yeah, they did submit a budgetary BDR, and one of the things we were doing up here is running through the statutes. And so I just wanted to reiterate for the subcommittee's edification that the department is absolutely correct that NRS 442 regarding the ATAP program makes reference to the health division, so there's that necessity for a sort of housekeeping kind of BDR. And in addition, there's the NRS 442-180 through 230 that pertains to children with special health care needs, otherwise known as the Special Children's Clinic. And while that's not precisely a Part C service, to the extent that that is housed within EIS, the references to the health division would be eliminated and the references to aging and disability services would be substituted. So I think the subcommittee can rest assured that there would be a BDR that would go to, at the very least, the money committees, if not the policy committees also. And there will be time set aside in the 13th session for the full legislature to contemplate the policy change that's been under discussion.
Okay, thank you. Do we have any questions from down south?
Yes, Mr. Chairman.
Please.
Thank you. Mike, and we understand how this works. It's like a game of telephone. One thing gets said on one end, a work order shows up at IFC. The next thing you know, you've got a whole division trying to figure out. I mean, the word pilot program is used. People remember the history of NEIS and how there's been discussions on the changes within NEIS. Over the last 10 years that I've been around, it's come up every 2 to 3 years. So you know the history just as well as I do. And, people have been through this before. They get a little hinky. They get a little nervous. They're wondering if their agency's the one that's going to get cut. And our ultimate goal is just to make sure that the money that we allocate to these work programs actually serve the children, but yet all these other things get wound up into this mess. When I'm looking at their proposals and they say October the 1st of this year we're going to start implementing some of these things, it makes me wonder, where are we in the process? The more information people have, the more comfortable they will always be with what's about to happen. I think this is just a symphony of miscommunication all the way through, but changing the money from one work program to another, all the other things that are going on, people are just wondering, what's happening. And now that you've put on the record that those employees will be there and the children are going to get served, hopefully, they won't blow up my email every other day, reaching out to me trying to find out what's going on. But I know there has been a lot of misinformation out there, and I want to thank the chair of the IFC and the chair of this committee for spending over 4 hours discussing this issue so that we really know what's going on and people can ask good questions and get some good answers. So I know you have a lot more to do in your morning. Mr. Weldon than spend 4 hours with us on something like this, but I do appreciate you being there and understanding what the process is within this. And I still have concerns, but hopefully as we work through this, you and your staff will be able to alleviate those concerns, because the last thing I want to do is find out we've done something and the unintended consequences were we caused more harm than good. That's the scariest thing in being a legislator, that you've made a decision to move some money around or give treatment in a different way, and you've actually hurt someone in the process. So hopefully by having these discussions, we will be able to eliminate that possibility. So thank you for coming up and putting your viewpoint on the record, but as I said, I still do have some concerns.
Thank you. I appreciate those concerns, and I think we have the same end goal in mind, and I'm happy to continue to work with this body, the full IFC, or your staff, or whatever, as we roll it out further. Obviously, many more details will be available Monday when the statutory release of the agency request is released. People will be able to see a lot more. And then, as you all know, there's a couple more months of working from agency request to GovRec. That's a confidential period. I think one of the frustrations are, as a state agency, and we all know this process, it's just the confidentiality rules. We don't get to communicate as many things as we could, and then we get the misinformation going, and lots of people, I've had probably, I doubt I have as many emails as you do, but we have had a lot of emails and a lot of fear about we're just laying off 170 people and there will be no NEIS. And that is the furthest thing from the truth.
Okay.
And so
a
letter will be going out on Monday to staff, hopefully communicating some more direction. That letter's been prepared for several weeks by the NEIS and staff who have worked on this. It just hasn't been able to be communicated until Monday.
And we appreciate that. And Mr. Chairman, if I may, there's been a number of concerns on the community provider side, and this meeting, I think, has done a lot to alleviate some of those concerns. Also, ultimately, it is the state's responsibility. We will be held accountable for what happens to these children. So hopefully we didn't cross any lines in asking any of the questions to either your staff or to the private or nonprofit staff that are out there, but it's our job, so we need to do that, and we just want everyone to know that's what we care about, is the kids, and this won't be the last time we have this discussion. So thank you very much, Mr. Chairman.
Thank you. Do we have additional comments from Southern Nevada?
Mr. Hamburg? No? Seems like none. Thank you.
Okay, thank you. From up here, nothing? Mr. Weldon, wait a minute. I always bat last. Come on.
Cleanup hitter.
Cleanup hitter, that's right. And I appreciate the feeling that we're on Mars. I've been feeling like that for quite a while. And I guess I've just got a couple specific items I want to cover. Certainly the points that the physicians put on the record about their concerns, a lot of those were the non-Part C services that, perhaps you would say are items that will certainly continue. I'm just thinking in terms of the urgent feeding team and some of these other items. Can you provide some assurance today that those services are going to continue with the new model?
You can correct me where I go wrong, but I was listening intently when the physicians were talking, and I have their list of concerns.
Good. Okay.
I was very shocked. Again, if there's any intent on anybody's part, I would want to say absolutely not to disrupt any level 3 NICU status. I don't really know where that's coming from. The state could lose $550,000 in a LEND program. That's not been discussed in my office, and I don't know how. I don't know what the thought process is on that. I mean, staff can come and tell me something. The CAPTA, we'd lose the CAPTA program. Again, no thought process, no discussion. We don't intend to do that. Lose the urgent feeding team. That hasn't been discussed in my office. Again, there's some separation of what's Part C and what's not Part C. And again, this seems to be misinformation that people are concerned about their role or their life as they know it today. And I'm just, these are not discussions that we've had that we're trying to harm any of this stuff.
Okay. Well, if they are truly misperceptions, I guess the message that, and the subcommittee is not really supposed to be giving messages, but my own personal concern is that, clearly there was a community of people that has not been fully engaged in this discussion, despite the best efforts to involve other members of the larger community in this discussion. There's a segment that has not been part of this. And so, like it or not, that ultimately falls as a burden on your department. I, for one, would like to see that addressed, and I'm confident that it can be. I know you can. I know you understand the importance of keeping everyone in the loop to the extent that you can, obviously because of the budget process. But if you could take some steps to reach out and try to address some of those issues and hear the concerns that they have about communication. I mean, I understand the fact that, if you're hanging on to the directing of services and you've got the providers, that you can hopefully close the loop. But if I'm hearing that pediatricians are saying that they're not getting the information that they need, or that they've got concerns that they're not getting the information that they need to provide their care, then I want to make sure that that's addressed as well. And I guess kind of returning to Assemblywoman Carlton's point, and I think we're going to go into this further when the next IFC receives our report of the information that we collected. There still is this question about what is the legislature's role in this whole discussion, and I absolutely appreciate that. We got a little preview on the budget, and we're going to hear more about it. But the fact remains that things have been happening, and there have been moving parts ahead of the next session. I mean, it's not just the formulation of a proposal for the next biennium going forward, but it's this question of all the activities that have happened in the interim. And I understand the pressures of, dealing with the budget that you've got, of dealing with a short window of when kids can most benefit from these services and having to make some decisions on the fly. But nonetheless, clearly, members of the Interim Finance Committee are feeling just very bewildered about this whole process. And so I don't necessarily, I welcome a response if you have one, but I think as a preview for further discussion at the full IFC at our next meeting, we're going to have that discussion.
My comments in response would be, I would assure you that I will be present at the IFC. We'll help with that discussion. We can send some additional letters, information over to staff. I will assure you I'll be in personal contact with the physicians that were up here trying to make sure that whatever miscommunication or misinformation, we'll try to get that straightened out. And then specifically to those 3 or 4 things that I talked about, the urgent feeding, the CAPTA, the LEND, the NICU status, we'll be on that Monday, and we'll need to be very clear about what our intent is on that, or what our intent isn't, or I will assure you we'll be on that Monday.
Okay, thank you so much. Okay, just it is now dark at the room at Elko, so I was really intentional about making sure we had that third site so that northeastern Nevada would be represented. So, oh well, we tried. So assuming there's no comment from there. If there's no, we can go ahead and close this particular item on the agenda. And now open up for our final public comment period. If there's more general comment from the audience, everyone's pretty much worked out. We're going to make it to first pitch. This is awesome. Thank you all for spending the morning and early afternoon with us. Next steps, as we've kind of discussed, is that all of this information that we've collected at the subcommittee will be formulated into a report given to the next Interim Finance Committee, which is the 24th, right?
27th?
I thought it was the 24th.
Thank you, 25th. It's that Thursday, it's the 25th. Coming up, and of course that meeting will be here in Carson City, so we certainly encourage everyone that's been involved in this issue to be present for further discussion of this issue. Thank you so much, and with that, this meeting is adjourned.